disease. Ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the one that's already beaten. Ask science, but science is humble. It will never breakthrough, because it has to reinvent itself every day. It never gives again and again. It keeps asking questions the breakthrough until it finds what it's looking for. We believe science can wants to cure people more than any disease wants to exist. Just ask the one that's already beaten, because in the end, ask science. But science is humble. It will never breakthrough, because it has to reinvent itself every day. It never gives again and again. It keeps asking questions the breakthrough until it finds what it's looking for. We believe science wants to cure people more than any disease wants to exist. Just ask the one that's already beaten, because in the end, ask science. But science is humble. It will never breakthrough, because it has to reinvent itself every day. The breakthrough until it finds what it's looking for. We believe science. Just ask the one that's already beaten, because in the end, ask science. But science is humble. It will never breakthrough, because it has to science. Because it has to save. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. When you want to save humans, just ask the one that's already beaten. Ask science, but science is humble. It will never breakthrough, because it has to reinvent itself every day. It never gives again and again. It keeps asking questions the breakthrough until it finds what it's looking for. We believe science can solve every any disease wants to exist. When you want to save humans, just ask the one that's already beaten, because in the end, ask science. But science is humble. It will never breakthrough, because it has to reinvent itself every day. It never gives again and again. It keeps asking questions the breakthrough until it finds what it's looking for. We believe science can solve any disease wants to exist. When you want to save humans, just ask the one that's already beaten, because in the end, ask science. But science is humble. It will never breakthrough, because it has to reinvent itself every day. It never gives again and again. It keeps asking questions the breakthrough until it finds what it's looking for. We believe science. Any disease wants to exist. When you want to save humans, just ask the one that's already beaten, because in the end, ask science. But science is humble. It will never breakthrough, because it has to reinvent itself every day. It never gives again and again. It keeps asking questions the breakthrough until it finds what it's looking for. We believe science.
All check. All 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. और वहां से जो बात कर रहे हैं उनका check 1, 2, 3,
Hello, Dr. Jenny, can you hear me?
Oh, hi there. Yes, I can.
Okay, good evening, doctor.
Good evening.
Can you just share your PPT?
Can I just share my screen?
Yes, yes, doctor.
Yeah, of course. Yeah. It says that participant screen sharing is disabled.
Just a second, ma'am. I'm just giving you the access. Hello, Dr. Jenny, can you hear me?
Yeah,
just
hi
check.
there. Yes, I
Just
can.
check. Okay, good evening, doctor. Giving you the access.
Good evening.
Can you just share your PPT? Are you able to share the screen now?
Yeah.
Yes.
Can you see my screen?
Full screen, ma'am. Right?
Can you see my screen okay?
Yes, ma'am. Can you move the slides? Yes, perfect, perfect.
Oh,
Yes, ma'am. I'll get back to you. Just be connected. Dr. Jenny. Dr. Jenny.
hello there.
Yeah, can you please share the screen again? PPT?
Share the screen again. Yeah.
The PPT. Yes. Slideshow mode.
Is that okay?
Move the slides, ma'am. Yes.
Okay. Do you want me to stop sharing?
Yes, you can stop.
Okay, great.
Dr. Jenny, camera बंद है. Hello. Professor Mayers, can you hear
Hello.
me? Hi.
Yes, I can. Yeah.
No.
Yeah, I can hear you. Yeah.
So we'll be starting the session not at 7 our time. 7 our time would be 1:30 your time.
Yeah. Okay.
Agenda is already shared with you. I have told all the speakers to stick to their timings. Gaurav would be in touch with you before, but then we'll hand it over to you. So our chairperson, Professor Suchitra Pandit, she is going to introduce you and then it will be to you. So what we'll do after your session, we have Dr. Shubha who will be presenting, and after that we would want, so once we are done with all our sessions, so sessions are comparatively very smaller, so short sessions, but more time we want to spend on question and answer.
Okay. Okay. So I'm going to start talking at what time? Sorry. I'm going to start talking just after 7.
Come here. So 7 if we are starting, then Professor Mayor is that time. They will.
Do you have an up-to-date copy of the agenda you could send me?
Yes, I'll maybe. Professor Mayers, are you able to hear Professor Suchitra Pandit?
Yes, I think so.
Hello.
Hello there. Hi. Okay. I can hear a little bit. I can't hear everything.
Yeah, increase the volume so that.
Yeah, that's better.
Yeah, and can we keep a mic somewhere there or near the so that the voice is louder? This is taking the place. No, for people to hear her voice.
So then she Professor Mayor will be speaking. Put that here because right now.
Yeah, can you, Professor Myers, can you say something right now?
Yes. Good evening, everybody.
Right. So yeah, speaker thoda sa loud kar or tell her to increase the volume. Kelan, they're trying to increase the volume. Yeah, hello. Can you say something again?
Good evening. How's that for sound?
Wonderful. That's great. Thumbs up.
Good. Great. I can hear you well. That's good.
Wonderful. Great. So, once you finish your talk, we will finish the entire session with the case presentations. And then, all of us will be here and we will have questions from the audience, which I will coordinate. That sounds okay? Right.
Yeah, that's fine.
Thank you so much.
No problem.
Good.
Around 2. So exactly it will be 2:10, but maybe 5 minutes here and there. So she would be online from 2 her time.
Right. Dr. Myers, your time is 2 p.m. the British time, the UK time, but you'll have to be online then, so that it might be 5 minutes here and there, but mostly by 10 past 2 we'll start. Okay, so that will be 2. It's 7 o'clock in India evening, so you'll have 4 hours behind us. So your timing is going to be 2 o'clock. Is that okay?
So yeah, I'm starting at 2 o'clock. And what time is the whole, how long is the whole session? How long is the whole event?
It's around 2.5 hours, but it might run a little more because sometimes people can get very enthusiastic with the questions.
Okay.
So, we'll keep that, a little 10 minutes extra. We'll keep that. Are you speaking from the hospital, or are you right now at your home? Or?
No, I'm in the car.
Okay, all right. So will you reach the hospital by then?
No. I'm afraid I have to stay in the car because my daughter is at her gymnastics training. So I have to, so I will be staying in the car for the whole time.
Okay, fine. As long as the connectivity is good, we are okay with that.
Yeah, I won't move. So the signal is good here. So it should be okay.
Right.
Yeah.
Okay. Thank you so much.
No problem.
right? So you can log out right now. Can we have your number, because just in case there's a problem, we need to connect with you. Okay, so yes, so that we can either call you or WhatsApp you. So could you send us your number? You can mail your number.
I've just put
the number. Okay, you put the number. Okay.
Yeah. So what, you want me to log back in at just before 2 o'clock my time?
Yes, please. Yes. Could you just put your number again, because we couldn't decipher the numbers, the digits.
I just put it in the chat, in the Zoom chat.
Yes, please put it in the chat. Okay, thank you. Thank you.
Have you got it? I put it in there.
Yes, we've got it. We've got it.
Right.
So you can log out right now.
Okay, and I'll see you in about 45 minutes.
Yes, please. Yes.
Okay, no problem.
See you then. Thank you. Bye-bye.
Bye.
So she can move in and move out.
When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because because it has to reinvent itself every day, prove itself again and again, until science makes a breakthrough. It isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the one that's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again, until science makes a breakthrough. It isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the one that's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again, until science makes a breakthrough. It isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the one that's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again, until science makes a breakthrough. It isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the one that's already beaten. But science is humble. It never rests, because it has to reinvent itself every time, prove itself again and again, until science
करताना इथे विंडो अशी दिसणार आहे ना, आपण हाईड करू शकतो. खाली गेलं का? छोटी करूच का? छोटी मध्येच फरक आहे. पण हा दिसायची काही गरजच नाही ना. हाईट सेल्फी करू, ह्याला मिनिमाइजच करून टाका, ते खाली जाईल निघून सगळं. हा, हे मिनिमाइज करून टाका, खाली निघून बस. पीपीटी झालं चाललं त्यांच्या. एवढं तर एवढं येईल. काय हा पीपीटी चेंज करायला शेअरिंग. एकदा आपण शेअर केलेलीच आहे ना, फक्त ऑन करायची पीपीटी. दोघांचे स्वतः ऑन करायचे ना. आपल्या Hello, Dr. Devan. Hello. Can you,
Hello.
yeah, can you hear me?
Yeah, I can.
Can you try sharing your PPT 1 second, ma'am?
Say again.
Yeah, your PPT presentation.
You want me to share? Yeah.
Try sharing. Okay, got it, got it. Yeah, thank you.
Okay.
Hello, Dr. Devan.
When you want to save humans from disease,
Hello.
ask science. It will make the breakthrough. Because science is relentless. It never gives up.
Yeah, I can.
It keeps asking questions until it finds what it's looking for.
Say again.
Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science
me
is
to share?
humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up.
I can.
It keeps asking questions until it finds what it's looking for.
Say again.
Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. To cure people more than disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests, because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It keeps asking questions. Any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough. Because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself again and again. Until science makes the breakthrough, it isn't done. We believe science can cure every human disease, and we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless. It never gives up. It keeps asking questions until it finds what it's looking for. Science wants to cure people more than any disease wants to exist. Just ask the ones it's already beaten. But science is humble. It never rests because it has to reinvent itself every day, prove itself. We believe science can cure every human disease. And we're going all in. Because in the end, science will win. When you want to save humans from disease, ask science. It will make the breakthrough, because science is relentless.
Good evening, everyone, and welcome to BMJ Masterclass. We really apologize for this delay and hope we are going to compensate this during our sessions. Thank you so much for your presence. My name is Dr. Simi Kaul, and I'm Senior Clinical Editor with BMJ. BMJ, global knowledge healthcare provider with the vision of creating a healthier world. We share knowledge and expertise to improve patient outcomes and your experiences. Our broader theme today is high-risk pregnancy, and we'll be talking on hypertensive disorders in pregnancy. Our last masterclass was talking about diabetes in pregnancy. We'd like to thank our sponsors, Pfizer, for supporting this event. We are glad that we are connected with 16 hub locations. From Chandigarh, we are connected with Dr. Mangala Dogra, Dr. Sonia Nayak from Delhi, Dr. Shailendra Jain, Jaipur, Dr. Renu Laktakia, Lucknow, Dr. Aarti Luthra, Dehradun, Dr. Shanti Roy, Patna, Dr. Ghosh from Kolkata, Dr. M. Tripura Sundari, Hyderabad, Dr. Navamani, Chennai, Dr. Joy George, Kochi, Dr. Sumati N, Madurai, Dr. Shilpa Nayak, Pune, Dr. Shabana Sultan, Bhopal, Dr. Asha Jain, Raipur, Dr. Shilpi Shukla, Baroda, and Dr. Indu Singh, Varanasi. We welcome you all. Quick announcements before we begin. We'll request you to switch your mobile to silent mode. It's a kind request. If your call is very important, you can step out and take your call. We are running the sessions back to back. And I think because we are late, we are going to compensate this. And therefore, we are taking the questions at the end. So we'll request all the live audience to write your questions on the paper and give it to us. To all the hub locations, the kind request is to post your questions along with your name and the city you are connected. For the live audience, there is a QR code which is kept on the table. We'll request you to scan the QR code and please share your feedback. It'll help us shape our future events. With this, we'll begin our scientific feast, and I'd like to welcome our chair, Professor Suchitra Pandit. She's past President Foxy ICOG, current President Justosis India, Senior Consultant Ops and Gynae, Surya Group of Hospitals, Mumbai. Over to you, ma'am.
Thank you very much, and good evening to everybody. And thanks, first of all, to BMJ for giving all of us an opportunity to interact with you. And I'd like to say, welcome to all the people from the hub locations. Sorry, we're a little late, but we'll try to catch up and we'll try to finish everything in time. So we all understand that hypertensive disorders of pregnancy are a very, very important cause of maternal and perinatal morbidity and mortality. And though we are saying the incidence of hypertensive disorders is between 8 to 10%, it could probably be much more. What we have to do is we have to update our knowledge on the prediction, prevention, the management, and at the same time, what exactly we can learn from our colleagues overseas. And we have Professor Jenny Myers, who will be also joining us in a very short while. We've already spoken to her, and she's completely ready with her presentation. So I am going to just give a quick introduction. I will be speaking on updates on prediction and prevention. Then we have Professor Jenny Myers. She's the clinical professor at Manchester Maternal and Fetal Health Research Center. She's a consultant at St. Mary's Hospital, Manchester, and scientific editor of the PIOS Med Secretary. And she's also the secretary of the RCOG Bell Blair Research Society. And she would be speaking on monitoring and eclampsia and discussing about the trend of antihypertensives that are being used. And we have our national faculty, Dr. Gorak Mandrupkar. He's a member of our Justosis. In fact, he's secretary of the Justosis India Association, past chair of the Medical Disorders Committee of FOXI, currently the director at Mandrupkar IVF Center, Islampur, Maharashtra, and he's been a great support for developing the GCPR of Justosis and FOXI on hypertensive disorders. And then we have Dr. Shobha Gudi. She's from Bengaluru. She's currently the professor and head of department at St. Philomena's Hospital, Bangalore. And she's just finished her tenure as chair of the Family Welfare Committee of FOXI, and done tremendous work on promoting the awareness of contraception and use in all the stratas of society. And both these, in fact, all three of us are part of the core committee of Justosis India Association. So I think it's time for us to start off. And once again, we apologize for the delay, but I'm going to just start in a few seconds. Sure. Slideshow करते हैं ना, नहीं करते हैं slideshow. I need a slideshow. It's not happening. Come up and do it now, please. Slideshow with me. Sorry for those technical hitches, but we are all ready to start. And though we are starting late, I know we have definite times for which we can speak, but we have decided that, Simi is going to interrupt us wherever, we feel we're exceeding time. And of course, we then want to do the question and answer sessions at the end of the entire program. So we all understand that hypertensive disorders constitute a perplexing and a clinically challenging group of pregnancy complications that are the leading cause of maternal and perinatal morbidity and mortality worldwide. And as I said, 10% of pregnant women are involved. And preeclampsia per se is 3 to 5%. And the word HDP is now the word used. It includes preeclampsia, eclampsia, gestational hypertension, and chronic hypertension. And after PPH is number 2 for the maternal and perinatal morbidity and mortality. And what we must also remember is this preeclampsia is a disorder of widespread vascular endothelial malfunction and vasospasm, which occurs after 20 weeks and can present as late as 4 to 6 weeks postpartum. But today, when we are talking of preeclampsia, we used to always talk of proteinuria accompanying preeclampsia, but now that is no longer required because a lot of multi-organ problems can start with severe preeclampsia even without proteinuria. So beyond the diagnosis, we know that there's a very high unmet medical need for more reliable predictive markers. Why? So that we can intervene and probably give you better outcomes. And research is focused, and all over the world, many groups have been talking about it. And ability to prevent a preeclampsia would be great if we have better predictive markers. So let's first of all look at the most exciting discovery of this decade, which we feel as Indians is a great boon. And this is a newer screening tool, the discovery of the gestosis score done by the core committee. And we have, actually got it validated also. This is based on detection of the high risk factors, and the concept was initiated and developed by the core group. Dr. Gorak Mandrupkar is here, Dr. Gupte, Dr. Girija Wagh, Alpesh Gandhi, and myself. And Gorak has also developed the gestosis app, which we will talk to you about just a little later. It has been validated at 2 centers, and the first study is already published in the Jogi 2022. So we are very excited about this particular thing. And what does it involve? It focuses on the clinical characteristics. And out of this, the ones which are on the left side are given the grade 1, women who are born themselves as small for gestational age, and then the age of the woman less than 20, more than 40, obesity, which was not considered earlier, but now if there's a BMJ of more than 26 to 30, nulligravids, a family history of preeclampsia or cardiovascular problems, PCO, which we are seeing now more and more, if there's an inter-pregnancy interval of more than 5 years, and maternal hypothyroidism, all these get a score of 1. The score 2 is given when there is obesity more than 30, multiple pregnancy, and gestational diabetes. And then 3 goes on to if there's a history of HDP in the previous pregnancy, pre-gestational diabetes, chronic hypertension, the thrombophilias, be it inherited, be it acquired, mental health issues, maternal chronic kidney diseases, and assisted reproductive techniques. In fact, ART also goes into the score 1, but when you're talking of the score 3, you're talking of ART excluding IUI. So when you're talking about this Gestosis India scoring system, at the first antenatal visit, a careful history is taken. It can warrant attention to all these markers. So you just start giving points. And if the sum total of the points is 3 or more, the woman should be marked as high risk. And what is the intervention? Simple, straightforward, easy. Start off with low dose aspirin 75 to be started along with calcium 1 to 1.5 grams, particularly in the low calcium intake group, as soon as possible, and continue it right up to the time the patient goes into labor. 48 hours before delivery, if you know the time of your inducing it, you can start 48 hours before. So this was the app which was designed by Gorak, the Android app. It's available. Download it and you can start using it. And many people have actually got printouts and put it on their case sheets, and they quickly give the marks and they start off with that easy intervention. The second one is obviously we all know about it, measurement of BP. The only important thing is correct measurement, because if the woman is obese, you need a bigger cuff. If the woman is very thin, need to take it correctly. Otherwise, you will make a mistake in taking the blood pressure. And Corot cuff 1 for systolic and 5 for diastolic is what is important. And obviously, if the diastolic is persistently less than 40, then you can take the muffling of the fourth sound. Correct BP equipment, important. Most of us have got the old mercury sphygmomanometer, but many places they're using the calibrated aneroid devices or the automated BP machines. Just remember, every time the patient is taking a BP at home, time and again, get those automated BP machines calibrated to the standard ones. And these are again standard precautions, I think everybody knows. But 2 points I would like to emphasize. The woman should be comfortable. Let her rest, let her bladder be empty, and she shouldn't be chewing tobacco because you'll get wrong readings. And of course, there are all the other factors which we have to look into when we are taking the blood pressure. And for a correct assessment, 3 readings should be taken 10 minutes apart. But if the first 2 readings say systolic 140 and diastolic 90, you don't need to take the third reading. But remember, if a BP is 135/85, it's alert, which means it should be rechecked, and frequent BP checks at home should be done. And counsel the pregnant lady and her relatives. This is important, and the patient needs to come for a follow-up. And obviously, during clinical evaluation, we all are doing the standard, asking questions about, the headaches, visual disturbances, persistent, headaches, epigastric or right upper quadrant pain, and increased edema. But what are the predictors also that we have through ultrasound? Wherever access to ultrasound is there, uterine artery PI shows that there is an increased resistance to blood flow in the first trimester, which is coinciding with the development of preeclampsia. And color flow mapping, diastolic notch, we are no longer taking as an important point, but the mean PI is calculated, and a PI more than 95th centile is taken as a high risk. So the first trimester scan, 11 to 13 weeks, where you're looking at the nuchal scan and dual marker, not available everywhere, but wherever it is available, you're also doing the PAPE-MOM, and you're looking at the other factors. So if the PAPE-MOM is less than 0.5, it is predictive of placental dysfunction, which may lead to a growth restriction. But umbilical artery Doppler is the best for predicting the at-risk women with an early onset of gestation. So you combine the maternal and the uterine PI rates, and anytime you find that the PI is more than 2 standard deviations above the mean, it is taken as a screen positive, and this is the woman where you can start off with low dose aspirin and regular fetal monitoring. You also have the biochemical markers. We all know about the PAPE. If there is a low level, it is associated with a higher incidence of preeclampsia and fetal growth restriction. And placental growth factor is something which we have started using in the last 1 year. This is a vascular endothelial growth factor involved in trophoblastic invasion of spiral arteries, and maternal serum levels 11 to 13 weeks. There's a decrease in pregnancies with aneuploidies and impaired placentation. And in second and third trimesters, these babies could develop preeclampsia, could develop fetal growth restriction, and the mother could develop preeclampsia. So there are good detection rates, but then there are false positive rates too. So various factors have been combined, and what is found that maternal factors, mean arterial pressure, uterine artery PI, plus the placental growth factor probably give 81.7% detection rates for preeclampsia before 37 weeks. And that is again an impressive number. Now, quickly about the ASPRE trial. This was conducted by the Fetal Medicine Foundation. This combines the patient-specific risks and decides what the intervention could be. This combines the a priori risk from the maternal factors and tries to combine the biophysical and the biochemical measurements. This was a prospective multicentric study. I think most of you all will be knowing about the study, but what they found from this particular study was, if there is a result positive, then these patients tend to develop preeclampsia, and the false positive rates are much lesser. The predictive value, 77% is the sensitivity, and the rates in the data set used for the development are 77%, 38%, and 10%. So the results clearly showed that if there was a comparison of aspirin versus placebo. If you gave in aspirin, to the pregnant mothers who had a positive test, then it resulted in a 62% reduction in the incidence of preterm preeclampsia. And there wasn't a significant effect in the reduction of the incidence term preeclampsia. And this was again the part of the study, though had a large number of pregnancies, the number who actually were recruited were not very large. So this was what was the study population, and around 806 patients were assigned for placebo, and around 785 were assigned for preterm for the low dose aspirin. So they combined all these maternal factors. They looked at the mean arterial pressure, and then they gave a risk ratio with the help of the Fetal Medicine Foundation calculator. And whoever came out as positive were given 150 milligrams of low dose aspirin starting from the time the results came, which is about 13 to 14 weeks, up to 36 completed 37 weeks. Now, what are the implications in practice? NICE guidelines look at the combination of high-risk factors. They look at 10 factors, but this screening can sometimes miss out, and they probably have a poor detection rate of only 39% with a false positive rate of 10. Whereas ACOG looks at the use of aspirin only in those women who have got a history of preeclampsia in more than one pregnancy, and maybe they've had a preterm preeclampsia and a preterm delivery less than 34 weeks. But then they've missed out a lot because they get only 0.3% of the pregnancies. ASPRI trial, on the other hand, says, well, we are combining the a priori risk. So we have a better detection rate, and they have advised giving 150 milligrams of aspirin, and they say that it reduces the incidence of preterm preeclampsia by more than 60%. So when they are looking at that, what do? We found that the use of Gestosis score is much more simple, practical, and we started the time the patient comes to us for the first time. She may have access to ultrasound, great, but if she doesn't, this is a very, very easy to use score. And we have a lot of centers and a lot of medical colleges who have now started using it. So maybe in the coming 2 years, we'll get a lot more data. And currently we have the WHO trial. Dr. Gorak just informed me there are 2 other studies which have come from China, which are clearly saying avoid using 150, probably use 75, because the side effects are much more lesser. Side effects to whom? The mother and to the baby, and the abruptions. So currently the debate still goes on between 75 and 150, but we'll have the discussion during, when we have a question answer session. Angiogenic biomarkers, SFLIT is the newer addition. Well, it was there, but we in India have started including it in our armamentarium. And basically, it is an anti-angiogenic protein which antagonizes growth factors. And what happens is the levels of SFLIT increase prior to the onset of clinical disease and appear to correlate with the disease severity. So if there is a ratio you're taking, the raised SFLIT upon the decreased placental growth factor, this gets elevated prior to the clinical onset and could alert the clinician. This is expensive. I was just talking to Gorak. It adds on 2,000 rupees to the already existing first trimester markers. But this was the basis of the prognosis trial. And today, they have clearly said it is an invaluable aid in diagnosis of preeclampsia and discriminates between various types of pregnancy-related disorders. But probably it is accessible to just a few people. It is not, when you're talking of things which are available and accessible to everybody, they're still not available to everybody. A value of 38 or lower can predict absence of adverse maternal and fetal outcomes. And there are many companies which have developed their products based on this particular value. And if, as I said, the value is less than 38, you're okay with that. But if the value is more than 38, then you have to be a lot more alert. So adoption of SFLIT and placental growth factor probably has the potential to reduce the frequency of adverse events, provided it's available. If it's available, do it and hospitalize the patient and consider delivery. Just a quick word about the PARROT trial. They found that people who are coming to triages, they were admitting patients with the BPs were high. But what the PARROT trial found out was that if the placental growth factor is tested at the same time, and if the value is suggestive or a very critical value, at that time the patient could be admitted. Otherwise you have unnecessary admissions. So in that trial, a single placental growth factor test was done to all the patients who were coming to the maternity triage. Those who had a positive test result, it halved the time to diagnose preeclampsia and significantly lowered the chances of serious complications. Parrot 2 is also going on. So these are the angiogenic biomarkers which have got a good sensitivity, a good specificity, but they are costly. And EVICO screening is one of the ones which we are using currently, but it costs money, and it has been sort of in accordance with the fetal medicine guidelines, and it tells us which woman is at a higher risk for preeclampsia. This is what the test result looks like. And then they have newer variants of the test which they're developing, the advanced test, but obviously everything is going to be costing money. So this is what the test results look like. So there is another thing which I should tell you, the full Pyers risk reduction model for the early onset. And this is the ability to recognize women at the highest risk of complications. And the full Pyers looks at all the factors. It'll identify women who should get admitted early in similar settings, and particularly the women at the highest risk. And this full Pyers was one model, and the second one was the mini Pyers. So the full Pyers has got all the histories that we talked about earlier, and the mini Pyers, along with these high risk factors, also has factors like parity, gestational age. Then they have got all the symptomatology, and they use pulse oximetry. So full Pyers and mini Pyers are also available, but in the full Pyers, they add on investigations, like a lab platelet count, like a creatinine, like the SGPT, SGOT. And then they say, well, it's positive and this patient should be admitted or shifted immediately to a higher care center. For our countries, the Southeast Asia, there was a wonderful trial which was carried out at Bangladesh and Mexico. Misfolded proteins in the urine of women with preeclampsia bind to the Congo red dye, and you get a positive test because of the color change. And this was again a prospective diagnostic case control study in 409 women. And they found that wherever there was a urine Congophilia, they call it, in this case, probably the patient is likely to develop preeclampsia. So they call it the GV positive test, positive in 85% of clinical cases and negative in 81% of clinical controls. And they say, well, this is a beta prototype. It's a point of care test, and probably this may help our Southeast Asian group and looks like a positive tool, but we are waiting for it to be available in our country. Few more minutes before we pack up. Newer research, just you need to know that we are aware that there are high levels of cell-free fetal hemoglobin in placentas of patients with preeclampsia. And HbF, if it is high, it has a property of oxidative tissue damage. Again, A1M is a protein which is identified as a reductase and binder of heme groups and organic radicals. And it is suggested that AIM has got properties that can protect cells and tissues. So if there is a reduced concentration of AM1M in patients who are having preeclampsia, this can actually be supplemented. It's like an IV supplementation of recombinant A1M. Short study, but it looks promising, but till it comes out in practical, we will not know about it. Again, removal of soluble FMS like tyrosine kinase, and this is with the use of dextran sulfate. So what here they say is, if you're going to use dextran sulfate for these particular groups of women, then probably it will remove the SFLT levels by 18 to 20%, and this will be seen in better protein creatinine ratios. And this was done also in a small sample size of just 12, but these are some of the things which are happening. They found that there was a continuation of pregnancy for 15 to 20 days, which is also sometimes good when we have very, very preterm preeclampsias. We are happy when we have this kind of a thing to prolong the pregnancy for a little more time. So this is also known as therapeutic apheresis, which reduces the SFLT and the proteinuria in women who are going to have or who are having preterm preeclampsia. Again, we have the emerging role of mesenchymal cells, and it is shown that human mesenchymal cells have got an anti-inflammatory, immunoregulatory and repair effects, and bone marrow is a major source. But today We have application human umbilical cord cells, which is rich in the mesenchymal cells, and probably the regenerative effects of this reduces the endotoxins and can delay the onset or prolong the pregnancy for a longer time. So what else do we need? I mean, those are all the research things. Basically, as clinicians, we need to get more aware. All our health workers, ASHA workers working in the periphery should know, should be alert when they know this woman has had a history of preeclampsia, and unfamiliarity with what is happening and very large amount of complacency still leads us to have the higher incidence of HDPs. So focused information in the antenatal period, in fact, in the preconception period, and looking after women in the postpartum period. So education of caregivers, very, very important. And once again, I want to reiterate the point, though we have fancy tests, ultrasound with Dopplers, biochemical, and advances are going on, today, public hospitals do not have trained manpower and biochemical markers. Government of India says minimum 1 scan in pregnancy. Ho jayega, so you do the second one. But Gestosis score is the easy, practical method of prediction. Doesn't cost us anything. Why don't we use it? So friends, please start using it. Congo red urine test, well, we are waiting and hoping that it comes in soon. So the last slide, we believe that we should have the Gestosis movement, which means early antenatal registration. Use the Gestosis score, and wherever positive, start off on low dose aspirin and calcium. Monitor these mothers. Don't leave them at home. Let them come back to you frequently. Monitor the BP. Teach the patients to do home monitoring. Use Maxel. Dr. Gorak is going to be talking about that. Timely transfer to a higher care facility wherever you're anticipating, and monitoring of BP in the postpartum period, which Dr. Shobha is going to bring out in her case presentations. Change of lifestyle, use of contraception, and advise these patients to come for a preconception counseling. Thank you very, very much. And I'm now going to request, we're not going to take questions right now. We're going to get on to our next speaker because she's already waiting for us, Professor Jenny Myers. So can we connect to her, please? So it's good evening, Jenny, Professor Jenny Myers. I've introduced you. So, we are very eager to hear your talk on monitoring in pregnancy and use of antihypertensives. So, everyone's waiting for you. Over to you.
Okay, well, good evening, everybody. Thank you very much for the invitation. I hope you can hear me okay. I'm going to just share my screen. Okay, so a lot to cover, and as ever, never quite enough time. So I'm going to focus on some highlights around monitoring and management of hypertension disorders of pregnancy. I work in Manchester in the UK. We work in a busy tertiary hospital, delivers about 9,000 babies a year on our site, and about 18,000 across 3 hospitals that are in the same hospital trust. And we have a very diverse ethnic population, and we receive a lot of tertiary referrals, looking after women with complex hypertensive disease and preeclampsia. So I'm just going to start with a little introduction about hypertensive disorders of pregnancy, talk about some clinical management highlights, focus a little bit on the treatment of pharmacological treatment of hypertension, and a little bit about diagnostic markers. So we know that that hypertensive disorders of pregnancy still account for enormous amount of burden, and are still very common, affecting around 1 in 10 pregnancies. We know that they account for an enormous number of preterm births globally, and still, unfortunately, high rates of maternal and perinatal morbidity and mortality associated with these conditions. In the UK, we're extremely fortunate that we have a very high quality maternal death recording, which has been in place for the last 70 years. And the risk of death associated with hypertensive disorders of pregnancy has continued to decline year on year that this report has been in place. And that's not because hypertensive disorders of pregnancy have become any less common in the UK. They're still as prevalent as ever, but it's really because of simple and supportive measures to recognise and manage these conditions that allows us to prevent maternal deaths. Unfortunately, we don't prevent our perinatal deaths as frequently because the penalty of preserving maternal health and keeping the mum alive is often delivering babies very prematurely. Despite the fact that the risk of maternal death in the UK is now very low as a result of hypertensive disorders in pregnancy, deficiencies in care and opportunities to improve care are still identified in every report. And I think we can all learn from lessons when there have been maternal deaths. And most maternal deaths are associated with unwitnessed eclampsia, and untreated severe systolic hypertension causing cerebrovascular hemorrhage, which is certainly still the most common cause of maternal death. And you all know that in terms of the burden of morbidity and mortality associated with hypertensive disease in pregnancy, that burden certainly exists outside of developed countries where there's easy and funded access to antenatal care, and we've still got a lot of work to do to reduce the impact and the burden of hypertensive disease globally. So you'll all be familiar, I'm sure, with the definitions of hypertensive disease in pregnancy, chronic hypertension being disorders of hypertension identified in the first half of pregnancy, in the first 20 weeks, and then gestational hypertension and preeclampsia traditionally being associated with new hypertension or worsening hypertension after 20 weeks of pregnancy. And one of the things I'm going to talk about today is how we identify superimposed preeclampsia in women who have got underlying hypertension, because that continues to be a challenge. Not surprisingly, management of hypertension, hypertensive disorders of pregnancy is really all about blood pressure. And if you have the tools available to measure blood pressure accurately, then you really can instill an enormous amount of good in terms of preventing the morbidity associated with hypertensive disorders of pregnancy. Accurate measurement of blood pressure allows you to identify those women at risk, both in early pregnancy and in later pregnancy. And it allows you to get women to the place where they can be have additional monitoring and have additional surveillance. Certainly in the UK, we are lucky enough to be able to encourage many of our women to do home blood pressure monitoring using validated devices. And I'm sure many of you have seen the Cradle device, which is a very easy to use rechargeable device, which allows accurate measurement of blood pressure and has a traffic light system, a green, amber, red warning light on, which allows it to be used by untrained healthcare providers who can recognise hypertension and escalate and move women to appropriate places of care. So focusing on blood pressure measurement both in early pregnancy and later on in pregnancy is extremely important. In women who present with hypertension at the beginning of pregnancy, we need to consider whether this is primary hypertension or secondary hypertension, and certainly taking a good medical history and considering some just simple investigations to exclude underlying renal disease can be particularly important in terms of the ongoing management of women with chronic hypertension. We have a very straightforward traffic light system for home blood pressure monitoring. Many of our women with both chronic and gestational hypertensive disorders will do home blood pressure monitoring. And we have a dedicated hypertension midwife team who are able to provide telephone advice for women when they're monitoring their blood pressures at home, which means that we reduce the number of face-to-face visits and we can get women into hospital when their blood pressure is changing. So in terms of the clinical management highlights, I mean, management of hypertensive disorders, the principles haven't really changed for many years. And these are kind of the basic principles for me in terms of managing hypertensive disorders. Prevent where possible. And I think that's been covered in your last talk. treat hypertension when necessary and consider issues around timing of delivery. And certainly for us in the UK, there is lots of ongoing opportunities to be contributing to the evidence base by recruiting women with hypertensive disorders of pregnancy into research studies. We've also got the National Institute of Health and Care Excellence guidelines, which are available to all and designed to help and outline principles around the management of hypertensive disease in pregnancy. And these are certainly the principles that we use in the UK to guide treatment. I've already heard mention of aspirin, and this is my plug, which I kind of have in every talk, really, to not forget that aspirin will reduce the risk of severe early onset preeclampsia requiring preterm births. You have to prescribe a lot of aspirin to make a difference in terms of reducing preterm births, but aspirin is a widely available and inexpensive intervention which is safe during pregnancy, and so all women with risk factors for preeclampsia should certainly be offered aspirin to reduce the risk of early onset preeclampsia. And in the NICE guidelines, we have some very simple clinical criteria which allow us to identify those women just on clinical history who are at increased risk of preeclampsia. And in most hospitals in the UK, this would mean around 25 to 30% of women in our clinics are offered aspirin to prevent preeclampsia. It's important to remember what we're trying to achieve with aspirin treatment. So aspirin reduces placental disease associated with early onset preeclampsia and fetal growth restriction. It doesn't treat term, small for gestational age, and it doesn't treat later preeclampsia. It really captures this group of women who have placentation abnormalities, who are on a path to developing early onset preeclampsia and early FGR. And it's important that women understand why they're being asked to take aspirin, because that certainly improves compliance. And we have a few principles, again, that we just try and reiterate with our women to just try and encourage them to take their aspirin, to try and explain why it's indicated, reassure them that it's safe, encourage them to take their dose at night, although as long as they take it daily, it doesn't really matter what time of day. We start around 12 weeks and we stop around 36 weeks. So I'm just going to spend a few slides now talking about the treatment of hypertension, why it's important, and what the common antihypertensive therapies are. So the treatment thresholds in the NICE guidelines, and I'd be interested to know if they're the same for you, are really women who've got sustained blood pressures above 140 or a diastolic of 90, regardless of whether they've got chronic hypertension, gestational hypertension, or preeclampsia, should be offered antihypertensive treatment. And we would have a target blood pressure of around 135/85. So the treatment threshold has reduced year on year, recognising that there is significant morbidity associated with untreated hypertension in all of these conditions. And therefore, we would offer pharmacological treatment to all women with a blood pressure above 140/90, which certainly makes things straightforward in terms of following the same principles for initiating treatment and target blood pressures. I suspect most of you are familiar with the CHIPS trial, which was published several years ago now, led by Laura McGee, which recommended or demonstrated that treatment of blood pressure with tight blood pressure targets was beneficial to the women compared to treating blood pressure with less tight targets. And one of the really important findings from this study was that treatment of hypertension was beneficial from a maternal health perspective, but at no increased risk in terms of small for gestational age in the children, in the babies rather, born to pregnancies where women had been managed to those tighter treatment targets. There had been concern in previous decades that over-treatment of maternal hypertension could give rise to excess rates of small for gestational age, but that wasn't borne out by the CHIPS trial. And what the CHIPS trial demonstrated very convincingly is that the number of women who experience severe dangerous levels of hypertension, so systolics above 160 and diastolics above 110, was significantly reduced if they were managed during their pregnancy to a tight blood pressure target. So that was convincing evidence, I think, that we should be managing blood pressure more aggressively. And then more recently, the CHAP trial has been published, and this was a US-based study that again randomized women to active treatment once they had a blood pressure of 140/90, compared to standard treatment in the US at the time, which was not to treat unless they reached much higher levels of blood pressure. And this trial again has shown that the reduction in women who developed preeclampsia with severe features, women who had an abruption, women with a perinatal death, and women with indicated preterm birth before 35 weeks was reduced significantly in the women who had active management and whose blood pressure was maintained during the pregnancy at less than 140/90. And again, very, very convincing evidence that there was no excess of small for gestational age babies in the group who were treated with blood pressure targets of less than 140/90. So 2 large multi-center international trials which have demonstrated that maintaining blood pressure below 140/90 is safe for women and safe for their babies. In terms of choice of medication, we have some decision guides which are freely available on the Action and Preeclampsia website and the APEC website, which I'd urge you to look at if you haven't already seen them, which just go through some of the common side effects and dosing regimes associated with the most commonly prescribed antihypertensives, labetalol, nifedipine and methyl-dopa. And we use this a lot when we're discussing antihypertensives and the choice of antihypertensives with women during pregnancy. But one of the things we also need to acknowledge is that we really don't have very good evidence of which of these antihypertensive medications, if any, are superior to each other. There's a very useful publication, again by Laura McGee, published 2 years ago now, which just summarizes the dosing regimes for the labetalol, nifedipine and methyl-dopa, which I would urge you to look at, and just encourages you to add additional antihypertensives if single therapy is not maintaining blood pressure below 140/90. Once you get up to a sort of mid-range dose of a single antihypertensive, it's probably beneficial to be thinking about adding a second antihypertensive if that is available to you. I think it's very important to consider the compliance issues and availability of medications in terms of what is going to be a sustainable treatment regime for maintaining blood pressure. And certainly that's an issue that we face here in the UK in terms of compliance with multiple therapies. It's not uncommon for me to have women on 2 or 3 different antihypertensive agents during their pregnancy. In terms of the initial choice of antihypertensives in the UK, there is, or certainly in the UK, there's wide variation in terms of the preference. We have all of these medications freely available to us, and so what determines what is prescribed is clinician preference. And you hear lots of people saying, oh, well, you should only prescribe labetalol for this reason, or you should only prescribe nifedipine for this reason. But actually, when you go to the evidence, there is very little evidence to suggest which of these antihypertensive agents is best and which agent is better in individual situations. Only 354 women actually included in RCTs which have compared labetalol with nifedipine, for example. Small amounts of evidence that demonstrate that labetalol and nifedipine possibly better than methyl-dopa in avoiding severe hypertension, but actually not very good quality evidence. Several years ago, we performed the PANDA feasibility trial, which looked at comparing nifedipine to labetalol in women with chronic hypertension. And this was a feasibility study to look at whether it was going to be reasonable to perform a much bigger multi-center randomized control trial comparing nifedipine and labetalol as the starting agent for treating women with hypertension during pregnancy. And that study is now up and running. It's called the Giant PANDA study. And it's running in 50 hospitals across the UK. Our aim is to recruit 2,500 women to that study, and we're currently up to around 900. So we've got about another year to recruit. And in that study, we're basically recruiting all women, regardless of the type of hypertension, gestational or chronic hypertension, who require antihypertensive medication and who are less than 35 weeks gestation, to be randomized to an initial therapy of either nifedipine or labetalol. And the primary outcome of the study is the avoidance of severe maternal hypertension, so avoiding blood pressures of above 160 or 100, 160 over 110, without increasing any adverse perinatal outcomes. Just a quick reminder in terms of the management of severe hypertension and severe preeclampsia. So certainly for us, the most common cause of preeclampsia with severe features is severe hypertension. And so in the UK, we have these management flowcharts or protocols, which are freely available in all maternity units, and I'm sure it's the same in India, where we would protocolize management of severe hypertension. And aggressive treatment of blood pressures above 160 over 110 will prevent severe cerebral hemorrhages and will prevent maternal morbidity. And so our focus for the management of women with preeclampsia with severe features is primarily to control hypertension, and we would do that with IV labetalol, oral nifedipine, and IV hydralazine. And I think that's the same in all units who've got availability of those drugs worldwide. We all know that giving IV magnesium sulfate is the next most important thing in terms of avoiding eclamptic seizures, or indeed treating eclamptic seizures, and that is the only anticonvulsant of choice in the setting of eclampsia. And the third principle of managing preeclampsia with severe features is the management of fluid balance. We know that women who develop severe preeclampsia have extremely leaky vasculature and are at very high risk of developing pulmonary edema. And the rates of pulmonary edema in the UK have been dramatically reduced by running women at fluid restrictions and maintaining a very careful IV fluid input around the time of birth and after birth in women with severe preeclampsia, so that iatrogenic or induced pulmonary edema is now very rare in the UK. And just going back to our maternal mortality, and just to bring this point home again, that those three principles, treatment hypertension, treating eclampsia using magnesium, and managing fluid. If you look at these blue and red dots here, these reflect changes in our national guidelines in the UK, and you can see instigation of these national guidelines with more aggressive antihypertensive therapy and fluid restrictions has been associated with reductions in maternal mortalities associated with hypertensive disease in the UK. So really good evidence over the decades that these guidelines and very clear and quite simple principles really do improve outcomes in women with severe preeclampsia. Again, in the publication by Laura McGee, just summarises nicely the various different doses and escalations of antihypertensives in an acute situation using either oral or IV labetalol, oral nifedipine, and IV hydralazine. And most women, well, all women in my experience will respond to IV hydralazine in terms of bringing down severe hypertension. Thinking about when we should deliver women with preeclampsia, a very tricky issue, and something that occupies much of my working week is agonising about when to deliver women who've got early onset preeclampsia. And again, these are our basic principles in the UK that we would follow, and these are the basic principles I think everyone should follow. So in women who are less than 34 weeks, we would manage expectantly with very careful monitoring of both maternal end organ disease, careful management of hypertension, maintaining a safe level of blood pressure, and very careful fetal monitoring. We're lucky that we have access to ultrasound, and we're able to monitor these women either as inpatients or on an alternate day outpatient basis. And so most of our women with all of our women with early onset preeclampsia would either be admitted, or we would see them alternate days in the clinic, and they would have a thorough maternal and fetal wellbeing assessment, and a care plan written which determines what level of variation would trigger early delivery. Between 34 and 37 weeks, we're now very lucky to have the evidence from the Phoenix trial, which was conducted in the UK, and we randomised women to immediate delivery versus expectant management when they presented with preeclampsia between 34 and 37 weeks. And the highlights which I discussed with women from the Phoenix trial were that 50% of women who were managed expectantly developed complications that required early birth. There was actually an increased chance of vaginal birth with early intervention in the women who were managed with immediate delivery. There was a reduction in the number of women who needed high dependency care amongst those women who had immediate intervention. But obviously, there was the conflict of increased risks of neonatal unit admission for babies born preterm. For women who present with gestational hypertension disorders, we would usually discuss and offer birth when they've reached 37 weeks because of the increased risks of ongoing maternal morbidity without really significant benefit to the baby. That's just more information on the Phoenix study, and some of you may be aware of the Cradle 4 trial, which has followed the same protocol and has been performed in several centres around the world from a more global health perspective. And that study has actually been completed, and the findings of that study have been presented at international meetings and will be published very soon. And suffice to say that in these settings, low and middle income settings, the benefits from a maternal morbidity perspective, but also really crucially, huge benefits from a perinatal mortality perspective, demonstrated by early intervention for women who were diagnosed with preeclampsia after 34 weeks. So no perinatal deaths in the women who were offered early intervention, no stillbirths or postnatal deaths, but I think there were 12 antepartum stillbirths in the group of women who were managed expectantly. So I would urge you to look at that publication. It'll be out very soon, which I think will be recommending early intervention or supporting early intervention for women with preeclampsia diagnosed after 34 weeks in all income settings. In terms of chronic and gestational hypertension, our strategy would be to keep watching for the development of preeclampsia, monitoring fetal growth and thinking of other obstetric risk factors which would mandate delivery. And we will have further data on the timing of delivery for women with chronic hypertensive disorders, or what you might call uncomplicated chronic hypertensive disorders during pregnancy from the WILL trial, which has recently finished and will be hopefully reporting quite soon. So I'm just going to finish by talking a little bit about diagnostic biomarkers in the setting of managing hypertensive disorders of pregnancy. And I appreciate these may not be available to everyone, but I think it's useful to just show where we're up to with the use of these diagnostic biomarkers in the UK. And the companies are working very, very hard to make these affordable and available in whole blood, such that they will be available to all income settings and all pregnant women in the not too distant future. So why do we need diagnostic biomarkers for preeclampsia? Many of you will be very confident in making a diagnosis of preeclampsia, and certainly for many women with preeclampsia, additional biomarkers are not necessary because the diagnosis can be made on clinical features alone. But there are a lot of women who present with gestational hypertension who actually aren't developing preeclampsia, and therefore their clinical course could be managed differently. Presentations of preeclampsia are often atypical and were always caught out by presentations which don't necessarily meet the standard clinical diagnostic criteria. But most importantly, certainly in my practice, I look after a lot of women with chronic hypertension, chronic kidney disease and diabetes. It's very difficult to actually make a clinical diagnosis of preeclampsia in women with background medical disease during pregnancy, and actually having an additional diagnostic marker is actually unbelievably useful. So we know that the diagnosis of preeclampsia is hypertension, very importantly, with evidence of either placental damage and or endothelial disease, vascular endothelial disease, and the proteinuria and the abnormal blood tests that we do when we've got women with suspected preeclampsia is really looking for evidence of endothelial end organ disease. The most common sign associated with end organ disease is proteinuria, and that's the diagnostic feature that we look for most frequently in women who present with preeclampsia. We also know women can present with biochemical and hematological abnormalities, and in some situations they may present with end organ complications, cerebral and pulmonary edema. And we know that fetal growth restriction probably complicates around 50 to 60% of women with a diagnosis of preeclampsia. We also now know from a whole host of literature that abnormal angiogenic biomarkers, so a low placental growth factor or an abnormal soluble FLIP-PLGF ratio, are also indicative and diagnostic of preeclampsia, and that's because they reflect placental pathology, placental damage. And so they delineate women who've got a change in their maternal features, so a change in their blood pressure or change in kidney function or proteinuria, which is attributable to underlying maternal disease. The angiogenic biomarkers actually confirm that there is placental damage, which is driving that change in the maternal symptoms and signs that we monitor as clinicians. So this is the kind of schema in terms of the pathway to the development of preeclampsia that we've had for many decades. Abnormal placentation at the beginning of pregnancy is associated with placental damage, the release of circulating factors, which causes and gives rise to altered vascular reactivity and endothelial damage. And it's that endothelial damage that we recognise as hypertension, proteinuria, and the other biochemical and hematological abnormalities. We know that women with background disease and background microvascular disease are more at risk of developing preeclampsia. And we now know that those circulating factors that come from the placenta, a large part of those are these abnormal angiogenic biomarkers. And we know that they are diagnostic of that placental damage, triggering that maternal phenotype. I'm not going to go through all of the evidence to support these diagnostic markers, but the first publication that we did back in 2013 was backed up by the prognosis study, which was done at around the same time, demonstrated in blinded samples that these were very accurate diagnostic markers of preeclampsia. And these markers were actually recommended by the NICE guidelines in 2016. We then did an implementation study in the UK, and in that study we were able to demonstrate that routine implementation of these biomarkers in clinical practice was associated with a reduction in the time to make a diagnosis, and also, and very importantly, a reduction in severe maternal adverse outcomes. So earlier identification of the disease was associated with a reduction of severe maternal outcomes. And because of that evidence, the updated NICE guidance published in July last year have now recommended this test to all UK-based hospitals, and it's now been adopted by over 90% of hospitals in England, with uptake catching up in Wales and Scotland. Very fortunate that this test is available to us in the UK, and as I said, the companies are working very hard to make this as affordable as possible, so that it can be made available much more widely, where it can obviously make a huge difference. So this is our pathway, and essentially if your test is normal and you're in the green column, you would go back to your normal level of surveillance. If your test is intermediate, we would put you on a higher surveillance pathway, and in our hospital that would mean weekly surveillance. And if you have a test in the red zone, we would put you on our high risk pathway and would usually either admit you or we'd be seeing you alternate days. Very importantly, this test doesn't determine when women should be delivered, but it determines the level of surveillance that should be offered to women who are at very high risk of complications when their test is abnormal. And this is our experience in women who've been tested with this in the last 18 months in our hospital in Manchester. This is 660 women who've been tested over the last 18 months. And you can see that one of the features of this population of women is that a lot of these women had, over 50% of these women had underlying medical disease, hypertension, diabetes, kidney disease, cardiac disease, etc. Just demonstrating how useful this test is when the clinical presentation is not straightforward, and it can be really quite hard to make a diagnosis. These are busy tables, but if I could just maybe get you to look at the middle section around high dependency care and the number of women who required high dependency care as associated with severe preeclampsia, as opposed to women who had underlying medical disease. And you can see in women with a normal soluble flip PLGF ratio test, the number of women developing severe complications associated with preeclampsia was very low. This is higher in the women with an intermediate test, but much, much higher in women with an abnormal test. And this has been shown in lots and lots of studies that the likelihood of developing severe disease is very much associated with having abnormal angiogenic biomarkers. Not to say that all of these other women should be ignored, obviously, and many of these women also need high dependency care, but the high dependency care that these women need is perhaps different, and I think that's really important. And they don't need magnesium, for example, they don't need fluid restrictions, for example. So I think it allows you to just stratify and target your high dependency care to those women who have got severe preeclampsia. And this is a very interesting publication from South America, which basically took a large number of women, several hundred women who had a clinical diagnosis of preeclampsia made by clinicians in a number of hospitals in South America. And they measured the angiogenic biomarkers and then looked at the pregnancy outcomes and looked at how pregnancies progressed, and demonstrated just how frequently there was a misdiagnosis of preeclampsia by the clinicians without using the angiogenic biomarkers. So they really do help, particularly in women with chronic underlying disease. So where they're available, and I appreciate not available in many centres around the world, but as they do become more available, I would urge you to grab them with both hands, because these really can make a big difference to how you manage hypertensive disorders during pregnancy. So in summary, I hope you already knew, but I hope I've just confirmed that detection and treatment of hypertension of pregnancy improves pregnancy outcomes. Simply measuring blood pressure accurately and facilitating women's movement to places where they can have close surveillance when hypertension is identified is associated with a very significant improvement in adverse maternal outcomes. It's very important to try and make a diagnosis so that the ongoing management of women can be optimised. We obviously need to use the evidence where we have it, and if there's an opportunity, contribute to the evidence where we don't. Thank you very much. I'll stop there.
Is being asked right away. Professor Myers, are you with us?
Yes, I am. I'm sorry, I couldn't hear. I couldn't hear them until
okay.
the last word.
Would you like your questions to be taken right away? Otherwise,
yes.
We had planned to do it at the end of the session because we have 2 more talks. Would you be able to join us later, or do you want to do it right away?
It would be, if there are any questions now, that would be useful, and then I perhaps might drive home and rejoin.
Okay.
Yeah.
All right. So I think we'll permit the audience to ask a couple of questions. So if anybody has anything to ask, I think people were concerned about the, from the hub sites, we got a question of dose escalation protocol. So they wanted a little more clarification on that.
Escalation protocol for
management of hypertension in pregnancy.
So we would escalate women for inpatient management and treatment if their blood pressure is above 160/110. And certainly all women who reach that level of hypertension, we would admit and be aiming to get their blood pressure under control as quickly and promptly as possible. For women with lower levels of hypertension, we would often still offer inpatient admission to get their blood pressure under control initially. It would depend on the circumstances, but what we're aiming for in all women really is to try and maintain blood pressure at 140/90 or less. And I guess depends on everybody's local arrangements as to how easy and possible that is. We're very fortunate that we can do a lot of that by home blood pressure monitoring and remote support. But I appreciate that's not necessarily going to be, so easy in all settings.
Right. There was one more question for one of the faculty, Dr. Gorak, and I think that was a question about labetalol.
Hello.
Hello.
So it was a very nice talk. I would like to ask regarding the dose of the labetalol.
Yeah.
That initially it was given in the literature as we start with 100 milligram BD.
Yeah.
And in many literature, it was written as BD to TDS.
Yeah.
And only in 2023 ISSHP guideline by Laura Maggie, she has written as QID. So it is little confusing about the oral dosage of the labetalol. Please.
Yeah. So what we're lacking really in pregnancy is really detailed pharmacodynamics and pharmacokinetics on labetalol. We are exploring that as part of our giant panda study at the moment, and we're actually doing some better pharmacodynamics, looking at blood pressure response to labetalol. But certainly in our previous work, we published that blood pressure, the blood pressure lowering effect of labetalol probably only lasts about 6 hours, 6 to 8 hours. And so for most women with significant hypertension, they actually need to take it 3 times a day, around 8 hourly. So I would only ever start it at 3 times a day, which is inconvenient for women, but actually is much more likely to get good blood pressure control. Most women, we would start at 200 milligrams 3 times a day. That would be our initial starting dose. But undoubtedly, I do have some women who need less than that. And so we do sometimes use 100 milligrams 3 times a day. But I would always give it as a 3 times daily dose. And then we would escalate it up by doubling the dose up to around 400 3 times a day, very occasionally 600 3 times a day, but usually by the time I get to 400 3 times a day, if that's not adequate, I would usually add in a second agent.
Thank you.
When you're adding the second agent, what is the optimal time interval between the 2 doses? Like you say, labetalol at 8 o'clock. When would you, if you've added nifedipine, when would you say is an optimal time to add on nifedipine?
Yeah, so we, again, it depends a little bit on how long women are going to have to sustain that blood pressure treatment regime for. So I think women with preeclampsia who are only going to be on antihypertensive medication for a few weeks, perhaps, you can be a little bit more specific about the timing. And so I would try and stagger it. So I would give the labetalol and then 2 or 3 hours later, the nifedipine, labetalol in the middle of the day, nifedipine evening, labetalol before bed, that kind of regime. For women with chronic hypertension, I think you've got to find a regime that they can sustain. And so taking 5 tablets at 5 different times of the day, many women find extremely challenging. So in that situation, we sometimes are much more pragmatic, and women will take their calcium channel blocker at the same time as their beta blocker in the morning and in the evening.
Okay. We are talking a lot about nifedipine. But the Japanese, they are using amlodipine and even nicardipine. So can we throw a light on that? Yeah,
so I haven't any experience with using nicardipine, but I do know there is, we have got some evidence out there on the safety of nicardipine. Amlodipine we do use very, very frequently. I'm a big fan of amlodipine. The reason we couldn't include amlodipine in our current RCT is because of the safety data, and we couldn't get it approved. But amlodipine is a very useful alternative with a huge advantage of being able to take once a day. So I use it a lot for women with chronic hypertension, and I also use it, it's my first line for postnatal hypertension. So I use it very, very frequently for postnatal hypertension for the simple reason that you can give it once a day. I'm not a fan of using labetalol for postnatal hypertension for the simple reason you have to take it 3 times a day, which with a new baby is very, very difficult. So once a day amlodipine would be my go-to. for postnatal hypertension. And as I say, we use it very frequently. We've just published a case series for about 400 women treated with amlodipine during pregnancy, and very useful medication if it's available to you.
Thank you very much.
And again, there has been a question from the subsite as to would you have any experience of prazosin? Because it is said that you can use it very, very sparingly. I mean, it's an alpha adrenergic receptor antagonist. So would you use it? Do you have any experience of that?
So we don't have prazosin available to us in the UK routinely, but we do use an alpha blocker called doxazosin, which is very, very similar. And I actually doxazosin is my usual third line antihypertensive. So I use alpha blockers very, very frequently in women with difficult chronic hypertension who need 2 agents. And I also use it very frequently in women who can't tolerate either calcium channel blockers or labetalol because of side effects or asthma. So alpha blockers, I think, prazosin, doxazosin, there are others available. Again, lacking all of the safety data and licenses that we need, but I do use them very frequently, and I know lots of people globally feel comfortable using alpha blockers if they're available. Again, very useful postnatally for breastfeeding women. We use alpha blockers a lot.
Dr. Myers, good evening. This is Dr. Shobha Gudi here.
Hi, good evening.
Hi, brilliant presentation. My question is on parenteral use of antihypertensives when there is accelerated and refractory hypertension. So you use labetalol initially, 20 milligrams dosage. Some query is there about the refractoriness of this, then what is the next that you go for? Which other medication you use for parenteral?
Yeah, so we use IV hydralazine. I don't know, do you have IV hydralazine available?
We have, not very freely available, I think.
Okay.
Not very freely available. Yeah.
So I find that there are a proportion of women who really don't respond very well to IV labetalol. And so we would give a single IV, we would give an oral dose and then an IV dose. And if there's been no response to that, within sort of 45 minutes, I would move on to a different agent. I would often give oral nifedipine because that will often work quite quickly. If the woman's able to tolerate oral medications, and it depends obviously on the clinical situation. If she's just had an eclamptic seizure, that may not be possible to give her oral nifedipine. And so in the UK, we would use IV hydralazine, and we give that in small intravenous boluses. And I've never had a situation where a woman has not responded to that. It is a very, you have to use it very cautiously, because it can cause really precipitate drops in the blood pressure and cause a fetal bradycardia. But if you give it in small IV boluses, 5 milligram boluses 20 minutes apart with continuous blood pressure monitoring, it's very, very useful to get the systolic down into a safe range.
Yeah, by the time, I think when labetalol doesn't work for such cases, we would have had some intervention on the physician and the critical care unit also.
Yeah.
And maybe the patient has to be shifted to the MICU from the HTU. And then we have had some experience with using intravenous nitroprusside for cases who are very refractory. And
and GTN infusions as well have been used in some
infusions also.
In some situations. So I think certainly nitrate donors potentially do have a place in that situation.
We have another question from the audience. Yes, please, doctor.
Yeah. Hello, Dr. Myers. It was a very informative and nice session. One question for you is, at what weeks of gestation do you correlate the SD ratio, that is the high resistance of the placental insufficiency? How do you correlate it? And at what the gestation do you want to bring that in as a biomarker?
Yeah, thank you. That's a big oversight that I didn't include that. Thank you for highlighting. So we wouldn't use the test before 20 weeks of pregnancy. And actually in my practice, I usually wouldn't use it before about 24, 25 weeks at the very earliest. The women that present with very early onset preeclampsia, you know, the women that present in that very early 22, 23, 24 week kind of presentation, usually the diagnosis isn't equivocal, is it? Usually, you know, they've got very severe early onset preeclampsia because of the clinical presentation and the severity of the fetal growth restriction. So we wouldn't usually use the test in that situation. So we most commonly use it around between about 28 and 35 weeks. We don't routinely use it after 37 weeks. And we use it much less frequently after 35 weeks. So really in that kind of 28 to 35 week range is where it's of its most value, I think, where potentially it's going to help you make timing of delivery decisions, and potentially it's going to be the thing that determines whether a woman needs to move, you know, between hospitals. So in the UK, for example, women needing very early birth would move to a tertiary unit, and so it can be helpful in that situation.
Thank you. Thank you so much.
Pleasure.
So thank you. For the time being, that's the list of questions, but I'm sure more will crop up as we go on. So whenever you reach home, please do log in again. So we will have the discussion at the end. Thank you very much.
Great. I'll see you soon. Thank you.
Thank you. May I now request Dr. Gorak Mandrupkar, who's going to be speaking on the role of magnesium sulfate in management of HDP.
Okay, good evening, all of you. Till then, that there is a solution of the technical problem, let us just, I request you all that you all have Android phones. Please go on the Android App Store and download the HDP Justosis Score app, because it is very simple, easy, and free of cost, and any level healthcare worker can use it for the screening of the preeclampsia, and it is validated, and soon it is accepted in many guidelines, and soon we are approaching WHO that for the low and middle income countries it will be the best approach, which will be absolutely free of cost. So it is my So it is sincere request that please go on to the Android App Store and download HDP Justosis Score. So today my topic it is magnesium, role of the magnesium sulfate in the hypertensive disorders of pregnancy. At the onset, I thank BMJ and Pfizer for this beautiful masterclass. We all know that the magnesium sulfate, it is a anticonvulsant drug of choice in pregnancy, and it is used, one, for prevention of eclampsia, treatment of eclampsia, and as well as there is a new emerging role, which is again recommended role as neuroprotection in the preterm infants. We all know that magnesium sulfate, it more than halves the risk of eclampsia, and it reduces the maternal death. It was compared with diazepam. It was compared with phenytoin sodium. There are many seniors here, they might have used like a cocktail. It was again compared with that. And now it is very clear that magnesium sulfate is the drug of choice across the world, in any part of the world. And that is beyond doubt. The next is, what is the mechanism of action? The mechanism of action, We all know it has a localized cerebral effect. It is a good vasodilator, but mainly it acts on the NMDA receptors, that is the N-methyl deaspartate receptors in the brain. And at various level, it causes the vasodilatation. Then there is reduced presynaptic release of the neurotransmitter glutamate. It potentiates the adenosine action, and by all actions, it brings out the smooth muscle relaxation, vasodilatation, and that's how it actually treats the condition. In India, there are multiple types of ampules and vials are available. Initially, it was available as a 25% weight by volume, then 50% weight by volume. Every time it was a 2 ml vial, but it was very difficult to calculate the dosages. So very simple advice that if at all still we are getting the ampules, then one should use the 50% weight by volume ampule, because one ampule is equal to 1 gram. In many classes, we have to tell this again and again, but that is a crux, okay, how to calculate the dosages of the magnesium sulfate. So for easy calculation, if we use the 2 ml vial, which is 50% weight by volume, each ampule, it contains the 1 gram. So it is very difficult to tell our staff, okay, but just bring the 4 ampules or 5 ampules, and it is in grams. But these are the newer preparations which are really available, and they are available in the vials, and that too they are available as 10 ml, 14 ml, 20 ml, 50 ml vials. Only thing that these are available in a 50% concentration. So we have to be very careful while using them, because the next top of my slide will be the regimen. And you all know that there are 2 regimens, one is Pritchard and one is Juspan. And there not only the route is important, but what is important is a concentration of the solution, because that matters a lot. Yes. We always must, because many a times it happens that we know what is Pritchard, what is Juspan, but we have never seen their photos. So it was my motto that at least we should see them, who is Pritchard and who is Juspan. Unfortunately, we are lost in 2007 and 2002 and 2009, both of them, but they are very recent people. Dr. Pritchard was again, he was the chief editor of our Williams textbook of obstetrics for more than 20 years. He's the only editor who was there for more than 20 years. So these are the 2 popular regimens. The first is Pritchard regimen. We must always talk again and again about this, because again, many a times there is a lack of monitoring facilities at many places. Though we are in metros, still there is a lack of infusion pumps and many things. So we must know the Pritchard regime as well. What is it? The loading dose is IV as well as IM, and the maintenance is only IM. So that is Pritchard's regime. So initially loading dose is 14 grams, out of which the IV is 4 gram. Again, this is very important. It is a 20%. So IV 4 gram, 20%, 20 ml over 5 to 10 minutes. IM 5 grams, again 50% in both buttocks. So total it became 14. How to prepare it? Again, it is my sincere request that in busy OTs, in busy labor rooms, one must keep the charts like this, because it will become a very easy calculation, and any level of the healthcare worker can help us in preparing the dosages. So if we take the 4 ampules, then and plus add 12 ml of the water for injection in a 20 cc syringe, it automatically becomes a 20 ml, 20% magnesium sulfate. And here we have to keep in mind 1 gram per minute. 1 gram per minute. That means it will take 4 minutes for that. That's it. If we give too fast, it is going to cause a problem, what we are very much worried of. Right? So we are always worried of magnesium sulfate, agar humne fast de diya, what will happen? So it is because if we give it as a bolus, it is not to be given as a bolus, but over 5 to 10 minutes. immediately one has to prepare the intramuscular dose. So 5 ampoules and it becomes 10 ml solution. For that, we take a 10 ml syringe. Again, you will say, why you are particularly telling the 10 ml syringe? It is again for the bore of the needle, because it is a recommendation that it has to go deep intramuscular. Otherwise, a lot of edema, then there will be flushing, even there will be pain. And if we have not taken proper asepsis, there is a chance of abscess. Even in 2023, I'm talking of injection abscess of the magnesium sulfate. So it is very important that we have to use that black needle. We are looking at lignocaine hydrochloride, right? It is an Indian government recommendation that we must add 1 ml to this whole 10 ml. It becomes 11 ml, and we have to use it because it is a very painful, though it is deep intramuscular, and this is a particular government of India recommendation in the intramuscular dose. Maintenance dose, it is again same, that we have to use 5 gram, right? Only thing every 4 hours. That is the recommendation. It is not like that ki hamare unit mein we used to give at 6 hours. Hamare unit mein we used to give at 8 hours. No, what Pritchard says is every 4 hours till 24 hours of the last convulsion or the delivery, whichever is later. That is the dose. So every 4 hours. If convulsion recur within 15 minutes of giving the loading dose, then we have to give 2 gram magnesium sulfate over 5 minutes. And if still it recurs, probably it is a time when we have to call anesthesiologist, and we may have to give pentothal sodium, or this is a probably case of status, should be shifted in ICU, and we have to take help of them. Zuspan's regime. Here loading is IV and maintenance is also IV, right? So loading dose is 4 gram, it is the same. IV 4 gram, 20%, 20 ml over 5 to 10 minutes, right? Now there is a crux. This is loading dose, same as it is maintenance dose. Now what actually Dr. Zuspan has written in his regimen, he has written as, okay, it should be, the infusion should be 100 ml per hour or 1 gram per hour, right? And there is a crux. See what happens if we are using infusion pump, and if we are using the high concentration solution, then it is fine. Otherwise, in our scenarios, we are using in this way. So we are putting 5 of the ampoules in 500 ml RL. So automatically it becomes 10% solution. And we have to give it for 24 hours. Then again, if you remember the previous lecture, she has already told that the fluid management, it should be 80 ml per hour. It should not exceed that. Because again, if we are adding some fluids, then definitely it is going to cause harm. So if we are using this regimen, then we have to be very careful about the total fluid management. If we are using in this way as a 10% solution, definitely we are exceeding the limit by 200 ml. So we have to be very careful while using this regimen. Second thing, when we are using the IV regimens, the serum magnesium monitoring is actually recommended by this regimen, which is not in previous Pritchard regimen. Because, whatever regimen we use, what milli-equivalent per liter of the magnesium gets as a serum level, it is 4 to 6 milli-equivalent per liter. And if it goes beyond that, then it is going to cause a problem of the uterine relaxation or the respiratory problem or other things, right? So whatever dose it is given in Pritchard or in Zuspan in a judicious way, it will never go beyond 4 to 6 milli-equivalent per liter. But this is very important. Before giving the maintenance dose, one must be assured of, number one, whether patellar reflex is present. Then there is a question, if we are not able to elicit it, or if patient is not able to move her leg, then what to do? We can see other reflexes. What we have to elicit is whether reflexes are present or not. If they are present, fine. Second thing, the respiration is not depressed. That means the respiratory rate is more than 16. And third is urine output during previous 4 hours has exceeded 100 ml. That means the kidney is working very well. So if all of them are fulfilled, then only maintenance dose. This is very clear. If all of them or one of them is not fulfilled, the management will differ. How? I will show that. Here again, the serum monitoring of the magnesium level has been advocated, but it is expensive, not easily available, and it is not superior to the clinical monitoring. That means if patellar reflex is present, if respiratory rate is good, not to worry, everything is fine. We can go ahead. Likewise. Now, so these are the therapeutic levels. This is again, I just quoted in a milliequivalent per liter, 4 to 6 milliequivalent per liter. And here it is millimole per liter. There is a conversion formula by into 1.5. Let us see this. So therapeutic levels with usual dosages, they are 2 to 4 millimole per liter. That means 4 to 6 milliequivalent per liter. If it exceeds, then it causes these problems. So not to worry about the respiratory depression. Please do not worry about the cardiac arrest and whatnot. So please don't, because for that, the level has to go more than 12. That means 6 to 7 times the more. It will achieve only when you are giving as a shoot, the first loading dose as a shooting, right? Or if you have not monitored and given the maintenance dose. Otherwise, no way we cannot, there is a problem. Suppose if there is absent patellar reflex, then not to worry. If respiration is normal, further dose of the magnesium sulfate, we have to withhold until the reflex comes back. So that means, okay, now the level of the serum magnesium has come to the therapeutic level, so further dose can be given. Here it may come that every 4 hours, though we are telling, it may delay by 1 or 2 hours. There is no problem. So unless until reflex comes back, we are not supposed to give the maintenance dose, but we should not withhold the dose forever. Maxup can be restarted if considered necessary once reflexes have returned, but at a reduced dose. Usually we give half dose, 2 or 3, like that. The next is, suppose urine output is less, reflex is present, respiration is fine, but only urine output is less. Then if there are no other signs of magnesium toxicity, then the next intramuscular dose to be reduced to 2.5 gram. And if you are using Zuspan regime, then the IV infusion, we should do it half as 0.5 gram per hour. That is a proper recommendation. We should not worry about it. And particular attention we have to pay towards the fluid balance and blood loss in future. Respiratory depression. That is the indication where we have to stop the magnesium therapy and we have to use the antidote. And the antidote is calcium gluconate. And how we have to give, it is a rule of 10. Everybody knows that 10 ml, 10% solution over 10 minutes, but with cardiac monitoring. Why do you know? Which drug is more dangerous? Maxelf or calcium gluconate? It is calcium gluconate because heart will stop in systole and we can't do anything. So the antidote is more dangerous than the drug. So we should not worry while using the drug itself. We have to give oxygen, maintain airway, and recumbent position. If it is arrest, we have to intubate, we have to stop the magnesium sulfate, we have to give calcium gluconate. But it is very, 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 very rare incidence. So not to worry. Minor side effects, one must understand. This is a very dangerous side effect. Flushing is the side effect mainly, and pain at the injection site. Other than nausea, vomiting, muscle weakness, drowsiness, these are there. In all cases of severe preeclampsia, right? So we have completed the management of the eclampsia by using the magnesium sulfate. There was a myth that magnesium sulfate works as antihypertensive as well. No, it is wrong. It has nothing to do with that. We have to institute or we have to give the antihypertensive therapy in whatever way as was discussed in the last talk, depending upon, and please, one more, as a Secretary of Justice India, I would like to give here one message that no case is mild, no case is moderate. Either the case is severe or it is non-severe. Because once we utter the word mild, our approach also becomes mild. So always we have to keep in mind, and that's why the newer classification has come with the ISSHP even in 2023. Justice India even in 2023 have come up with severe hypertension and non-severe hypertension. And then our approach will remain in that way. Now in the prevention of eclampsia, suppose we have the case of severe preeclampsia. How we do define? It is not only on blood pressure. So either the blood pressure more than 160, 110, or any blood pressure and premonitory symptom, or any blood pressure and abnormal blood investigation. So that is a case of severe preeclampsia. And in all such cases, we must give the magnesium sulfate as a full loading dose. It is not like that कि नहीं only IM देके रखते हैं या सिर्फ IV देके रखते हैं. No, it is not like that. We have to give full loading dose, and later on we have to follow the magnesium sulfate regime for 24 hours. And suppose in that, if patient settles, if the blood pressure is normal, and probably if we judge that okay, the expectant management can be continued, we can continue. So that is a very clear-cut message. Again, maybe it is a last or second last slide. The magnesium sulfate, besides being an anticonvulsant, it acts as a neuroprotector and vasodilator. There were so many questions which were there on the this magnesium sulfate, and one was if we want to use for neuroprotection, what is the dose? Same. If we want to use as a neuroprotection, should we continue for 24 hours? Yes. You choose which is the regime. So this is a very recent, even FIGO guideline that they have clear-cut mentioned that if you are planning the delivery, and where you require the neuroprotection, please use the same dosages, either Pritchard or Zuspan. But in that, FIGO has advocated the Zuspan regimen. So that is very clear-cut indication. Their patient might not be having hypertension. So we are using magnesium sulfate for the neuroprotection. That we have to keep in mind. And it is indicated in preterm cases between 26 to 34 weeks. That is our Indian guideline and the WHO guideline, while the FIGO says it is between 30 to 34 weeks. But WHO and Indian guideline says 26 to 34 weeks. Thus, this magnesium sulfate has, number one, the role in the treatment of eclampsia, prevention of eclampsia, and the neuroprotection of the preterm baby. Now, once patient is settled, initially we have to take a decision of the delivery, either induction of the labor or cesarean section. Again, you will ask that cesarean section. No, cesarean section is only for obstetric indications. There are so many seniors, and they will also agree that, in fact, the patients of eclampsia and the patients of cardiac disease, they progress very fast. If we monitor in a proper way, if we induce them in a proper way, definitely they are going to deliver. In fact, because there is a compromised hematology, if we do unnecessarily incisions, more and more incisions, it is going to cause a lot of problem. Cesarean delivery should be performed for obstetric indications only. Otherwise, vaginal delivery per se for eclampsia, it is not contraindicated. Induction of the labor may be performed with oxytocin. Yes. Last slide. Eclampsia kit. It has to be there. In every labor room, all these things, they should be there. The airways, the IV cannulae, sticking tape, IV sets, blood set, all these things, they should be there. Because many times it happens, we have done a survey of not less than 10,000 centers, and where we have found out that many times simple things are not available. We all know that if I am using Pritchard regimen, then at first sight, I want 14 ampules. So minimum at least 16 to 20 ampules should be there, because many times it happens that 2 to 3 ampules, they get cracked totally. And we are divided of the total dose. So even that we have to keep in mind. 20 ml syringe is not there. Many times it happens. Then the water for injection is not there. RL is not there. Many times 5% dextrose is there. Again, an advice that please discard the 5% dextrose from our labor rooms and for our OTs, because that is a very bad fluid. You know why? Because whenever we give 500 ml, out of it 120 ml it goes in the third compartment, and the patient already, she is swollen, she will swell like anything. So if we go into the guidelines of the anesthesia or the critical care, they say it is a very nonsense IV fluid. So we have to be very careful while using 5% dextrose. No 5% dextrose. Eclampsia room checklist, yes, all these things, they should be there. And so my take home message is, we have recently started a campaign through, because I am a chairman of SOP and Guideline Committee of the EMOGs, where we have started with Justice India, zero eclampsia by 2025, and which is possible because we have already reduced the incidence of pre-eclampsia. It is on definitely a lower side. So we can do the zero eclampsias by 2025. And for that, we have to use the approach, and that is called as Game 75. So we will do the game of eclampsia. How? G is for Justosis score. So please use that for prediction. A, antihypertensives, as what she has said, early at 140/90. Don't wait till 150/100 as a previous teaching. It was in previous days. Forget about it. Because in all trials, Chiefs trial, new Phoenix trial, everybody has proven. Now WHO has also started saying that at 140/90, one has to start the antihypertensive. A. M. Magnesium. Problem? Magnesium sulfate for in the prevention of eclampsia. And E75 is ecosprin 75 milligram for all women who are at risk to develop. So that is a game 75 to ZEC 25, zero eclampsia by 25. It is a drug of choice, should be given in a proper clinical monitoring. And for settings, this is very important message, that for settings where even if it is not possible to manage the patient, then one must give the loading dose and then refer the patient. So it is our aim that yes, please give the loading dose, please give the antihypertensive, please give the referral sheet in a proper way, which drugs you have given. Please call the center where we are referring the patient and then refer the patient. Definitely the maternal mortality and morbidity will definitely go down. And I must congratulate all of us. I'm saying all of us, because in India, the maternal mortality of Maharashtra has gone in 2 digits, and that is 33 next to Kerala. While the rest of the states, they have, like UP and Bihar, even still, it is more than 100. So it is efforts of all of us. Let us go towards zero. Thank you very much.
Leave the questions after Shobha has finished the clinical cases. Yeah.
Thank you.
Yeah, I think I'm more vertically challenged than Gorak is, and I'll have to take this stand, just like Suchitra ma'am did. So yes, I agree with you. And so that does the treatment of preeclampsia lies in those small vials and tablets that we have been talking about in the past 3 hours. So thank you very much, BMJ and Pfizer, for giving us this opportunity. And I was actually pulled into this by my mentor and advisor, Dr. Suchitra Pandit. In fact, I did perform as a committee chairperson in FOXY, and she was one of the leaders in FOXY who encouraged me. And so much till today, I think she leads the way in encouraging other FOXians to perform equally well. And I thank Gorak for setting the stage for my talk, because I think he brought in very important perspectives in prevention of eclampsia. Now, having said that, in this session, I will go really quick, and I want everybody to be very attentive. Over the years as speakers, we have learned to, speak as the first speaker and then also as the last speaker. So I do stand between you and a very hot, inviting dinner, but please bear with me. I will not take much time. So can I have a display on my screen? Okay, I'm sorry, I didn't know that the slide of my CV was on for so long. I didn't want that. I must begin by putting into perspective the levels of prevention of preeclampsia. We must understand that, this is the disease which, why is it not working? I can use this also, no? This is easier for me. Okay, all right. So it is a systemic disorder. It is not only uteroplacental or not only hypertension, it is an entire body is involved, the microcirculation everywhere. Pathophysiology is very poorly understood, and that is why prevention is so very challenging. Okay, the animation is not moving much, and my screen has gone blank. I'm sorry about all this. So the prevention is a challenge because the exact cause is not known. I think most of us understand, and therefore we know today that many more nuances of prevention have come. As Dr. Pandit spoke, Dr. Myers spoke, that prevention has become the key, and we can see the inverted, the pyramid is erect here, but now there is a concept of the inverted pyramid, wherein we put all intervention into the first 3 or 4 months of pregnancy. So we must understand that tertiary prevention is most often which we come across as practitioners, where there is already an established disease and we are trying to prevent the consequences of the severe disease. Secondary prevention is when there is a, please correct my screen. The secondary prevention is where we are trying, there is a pregnancy with high risk and we are trying to prevent with our strategies like aspirin. I am not successful with this. I'm very sorry. Please change this. And then there is a primary prevention where we need to understand that this disease being linked to pregnancy, it will be the solution will be in high risk women to have a limit on the family number and adequate spacing between 2 births. And that is how we are going to have primary prevention. Very quick take on the cases today, the case scenarios. HELP syndrome is one of them. Sorry. Okay, let me continue. So this is a 30-year-old unbooked primary with 37 plus 6 weeks. The presenting complaint said that, there was, sorry about this. Okay. She reported to a hospital ER with pain in the upper abdomen and multiple episodes of vomiting since 2 days, along with headache, frontal and occipital fetal movements, though she was getting well, but there were no other signs, symptoms of altered vision or pain or bleeding, leaking PV or decreased urine output, etc. So symptomatically, she was okay. Slideshow on this. The obstetric history revealed that she had a very, almost normal course in the first half of pregnancy. At 30 weeks, hypertension was found, and she was started on levetulon, and an ultrasound at 35 weeks picked up some FGR, though the Doppler was normal. Antenatal record did not reveal any other significant surveillance or intervention. So far, she has had a good course, but then she lands up in the ER. The exam findings was that she was okay at, conscious and oriented. Okay. Okay. All right. Hypertensive with a blood pressure of 150 by 110 with severe edema, obstetric examination, 34 to 36 week size. Is this the slide which I gave? The second one which I gave, because again, I'm losing matter on that. Okay, let me proceed. The investigations done were that there was severe albuminuria and LDH was elevated. Now, all this takes a little time to come. We sent the investigations, it takes a little time to come, though it is day 0, time 0 investigation. The platelet was 1.3, peripheral smear showed just hypochromia, and the renal panel was normal. Antihypertensive treatment was started aggressively, magnesium sulfate given, counseling done, both maternal and neonatal. induction of labor planned, and that is when we found that there was hematuria. All right, that is when we found that there is blood in the urine. So what did we do? We delivered her. We did a cesarean immediately. AMTSL was done, but still there was bleeding. The atonicity persisted. We gave medical management. We did suturing, and the estimated blood loss by the time we could get a hold on the situation was already almost 1450. So women with this kind of complication in preeclampsia have a very high risk of hemorrhage during delivery, and we need to be very armed with all blood component and therapy. During the surgery, she went into hypertension, because so we can see that she is a well-booked woman, though unbooked for us, had good management, reasonably good management, but still at surgery, she is hypertensive. Intraoperatively, we transfused and we shifted because there was reasonable hemostasis in the ICU. Of course, she needed intubation. Anyway, she was intubated for the surgery. It was done under general anesthesia. She was continued. The patient was on was given component therapy along with platelets. On POD1, the vitals stabilized enough for us to extubate, but the platelets remained low. And further transfusion, this time a single donor transfusion was given, and POD2, the platelet became 1 lakh. So HELP can be deadly. It's progressive and severe variant of preeclampsia. We might see in 10 to 20% of women, in maybe 15% of severe preeclampsia. The incidence is 0.5 to 0.9 of all pregnancies. Just under 1% is HELP. And please remember, there are about 30% of these cases where concomitant hypertension may not be picked up. So it may be only as a HELP syndrome, but though 70% is associated with severe preeclampsia. Maternal fetal complications are very, very common. There is significant perinatal mortality in this condition, mainly due to prematurity, and 1 to 24% maternal mortality, depending on how quickly the action is taken and how well armed the center is. It has to be at a center with adequate ICU facility, or in other words, a tertiary care center. So this is a situation where there can be acute kidney injury, eclampsia can be associated, press can be there, abruption, pulmonary edema, PPH, cardiomyopathy also is more common in HELP, sepsis, yes, multi-organ dysfunction, and mortality is possible. We also need to keep in mind those conditions which can come as differential diagnosis of HELP, namely thrombotic thrombocytopenic purpura and hemolytic uremic syndrome, though they are rare, and exacerbation of SLE sometimes. And we need to have a very discerning mind to keep in mind that to differentiate on the basis of investigation. Maybe we'll be able to touch on this as we go along, because there may not be time to deal with the entire list now. You can also see here that some of the laboratory investigations are a little, are something far-fetched for a situation like ours. Of course, thrombocytopenia, the diagnosis of hemolysis and DIC may be possible for us, but then doing ADAM-TS and VW factor multimers or etc. may not be. LDH is very significant, and we all know, and HELP is classified by Mississippi. The one thing important in HELP classification is normally we take 1 as mild disease and 3 as severe disease in any staging, isn't it? But in Mississippi classification, stage 1 is severe disease. It is severe HELP. And it is stage 3, which is milder. So please be aware of that, of those differences. So in this HELP syndrome case, the delivery saves mother and fetus, but reversal of the hematological parameters are not as dramatic as in eclampsia. Eclampsia, the moment we deliver, the woman improves, within hours. But here it may take 2 to 3 days, and critical care needs to continue. Monitoring needs to continue. There can be even fall in platelets for the first 1 day or so. LDH may take as long as the 4th postnatal day. And, this screening history for HELP in severe preeclampsia is very important. And classically, they will have upper abdominal pain. They will have mucosal bleeding. Hematuria is a classical example. Extreme fatigue. Okay, so if any woman sitting in front of us in the outpatient complains of extreme fatigue with or without hypertension, it makes sense to do a count, a complete blood count, look for anemia, also look for falling platelets. So extreme fatigue is an important picture. Petechiae on skin and icterus are actually rare. Recurrent help is possible, and low dose aspirin is the only prevention, because there is a history of previous, severe preeclampsia in this case. And as we know, Justosis score allows us to start aspirin on the basis of history scoring alone. So of course, primary prevention is the prevention of pregnancies, and women and families must be advised on limiting the size of family, which is also poorly understood in our communities. The other case is IUFD with placental abruption with DIC, severe preeclampsia with this, the triple picture of a fetal loss, an abruption, and a DIC in the mother, which all of us have faced during our residency and during our tenure as consultants. Now, abruption is classically a disease where placenta separates after 20 weeks of gestation before fetal expulsion, classified as mild or severe. Most often, we need to end the pregnancy immediately. Rupture of maternal arterial or venous vessels in the decidua bassalis is the direct cause of the separation, and that can be secondary to the damage of preeclampsia. So at admission, this lady is 31 weeker, primary gravida, 33 plus 5 weeks, non-hypertensive, and she has been referred to us by a government hospital. She comes with an intravenous crystalloid on flow, bag and mask ventilation, thready feeble pulse, hypovolemia, severe hypovolemia, and even as resuscitation efforts are going on, we take a history, and there is history of pain in the abdomen for about 4 hours preceding with bleeding per vaginum. And she reported to the above hospital, fell unconscious there, was resuscitated and referred because that did not have a ICU setup. There was no other history of impending eclampsia, but when we took the history, she was primary. All investigations so far were normal. Only gestational hypertension was picked up at 28 weeks, and she was started on labetalol, but then this was a sudden event, almost similar to the previous case. Now, these are true cases from our hospital whom we were able to save. Conscious, little altered sensorium, though no fever. Pallor was quite severe. Edema, of course, and as I said, tachycardic and hypotensive. Shock index of 1.5. I hope all of us are aware about shock index. It is heart rate by systolic blood pressure. More than 0.7 or 0.9 is abnormal. Obstetric exam showed 36 weeks tense tender, dark red bleeding, and the portable scan showed a massive abruption at the fundus. And since she was in hypovolemic shock, we took her to, she was admitted in MICU, stabilized, intubated with 2 BRBCs transfused rapidly, and we shifted to OT for a cesarean. At intraoperative, it was a cavalier uterus. There was a retroplacental clot, atonicity. There was diffuse bleeding from the muscle and other layers. Well, that happens in DIC, we all know, and we picked it up. We said this is going into DIC. Estimated blood loss was 2 liters. The hemoglobin had fallen. Serum creatinine was holding, but the counts were very high, and the platelets were less than 1 lakh. The enzymes, liver enzymes, were not bad, but the LDH was high. So there was also a blending picture, but we put it as DIC and sepsis, not as HELP in this case, because we soon saw that the INR had gone more than 1.2. It was repeated on the same day, it was more than 1.2. And on the peripheral smear, we saw that there was significant leukocytosis. D dimers were high, but that we know is not a very sensitive test. It need not be done in cases. We need to focus more on the INR and the fibrinogen level. Day 0, BP was not there after transferring from OT, and she went on to the pressor therapy with a central 9. We gave multiple component therapy, aggressive and MBT protocol, that is massive blood transfusion. We gave PRBC, FFP, STP, single donor platelet, and that brought her back on day 1. The Q-SOFA score of sepsis was 3 on 3. And she developed electrolyte imbalance, was corrected. We continued the replacement therapy, because as we can see, the hemoglobin was still 6 and the platelet was still less than 1 lakh. The liver enzymes had started climbing, probably due secondary to sepsis. The INR was still 2. So we went on with correction of DIC. By day 2, she had fever. 2D echo shows some effusions, etc. And since there was still the platelet less than 1 lakh, and still the INR was high. We again transfused FFPs, cryoprecipitate, etc. And then she kind of stabilized by postoperative day 3, and we were able to get an INR of less than 1 by postoperative day 4. So the take-home messages for severe preeclampsia and placental abruption. Abruption is a life-threatening event for the mother, and fetus occurs in 3% of those with preeclampsia with severe features, and 2/3 of abruptions are quite severe and are defined by more than one of the following findings: maternal DIC, shock, the necessity for transfusion or hysterectomy, renal failure in the mother, or even mortality. The fetus non-reassuring, growth restricted, even demise, and the newborn preterm, small for gestational age or mortality. More than 50% separation certainly results in DIC. So severity is defined by one or more than one of the following. So you can see that almost all cases of abruption should be regarded as severe. So please be wary about those group of people who say that you can have conservative management in small focus of abruption. Be very wary about that. And a fibrinogen level of less than 200 correlates well with severe bleeding, though I must say that we always see significant hemorrhage below 100 only, but be aware that she requires transfusion of component, especially cryoprecipitate. And abruptio placentae in particular with severe preeclampsia creates a situation of DIC where predominantly, there is a lot of consumption of the clotting factors in the bed of the placenta. Almost, total body component goes into that, the blood component for coagulation. They do require component therapy very aggressively, and most importantly, they require cryoprecipitate. So please be aware of that. And once DIC sets in, aggressive management should be done. So is it preventable? The question always comes, we have been talking about prevention for the last 3 months. Can we really prevent abruption in a woman who has hypertension? It is a little, difficult to prevent abruption, because sometimes we aggressively control hypertension. We are waiting for the steroids to act. Suddenly we lose the situation in the night because there is a massive abruption. It has happened to all of us. And however much we kind of self-flagellate the next morning, the situation remains that we were not able to prevent this. The best prevention is timely delivery. Yes, that trick we must balance severity against prematurity. LDA reduces the occurrence of preeclampsia in patients at high risk. So if it reduces severe preeclampsia, definitely it will reduce the consequences of severe preeclampsia. But once it is diagnosed, however, LDA also, the higher dose especially, there is a concern that there is a link to placental abruption because of the nature of its action. But once diagnosed, the disease progression cannot be controlled because most often when a woman develops preeclampsia, the course of the disease is already like a clock set with the placentation in early pregnancy. There is not much we can do except for very close monitoring and timely delivery. Antihypertensive therapy can prevent severe hypertension sequelae, will not interrupt the progress of the disease, but antihypertensive treatment, optimal antihypertensive treatment, will prevent the sequelae of severe hypertension, namely stroke or other cerebrovascular accidents and placental abruption. But we must also be wary about sudden drop in blood pressure. So it has to be a very adequate and smooth control of blood pressure. Should not aspire for lower than 120/80, for example. Magnesium sulfate therapy can prevent seizures, but it cannot prevent abruption. Early diagnosis of placental insufficiency is also important because it is seen that these sick placenta, where the placental component in preeclampsia is strong, these unhealthy placenta will have more tendency to separate. So beware of women who also have intrauterine restriction with preeclampsia. So this is an 18-year-old, 33-weeker, known preeclampsia, appreciating movements well, no other signs, symptoms of impending. First, second, and third trimester, she had raised BP, started on treatment, and when she was seen, she had, just a moment, she came in with the history of headache and 2 episodes of vomiting. she came in with signs of impending eclampsia. And she had a very high blood pressure at admission with a 30 weeks uterus size. The LDH and alkaline phosphatase, everything deranged at admission. Of course, that came a little later, but we found 2+ proteinuria immediately. We found a low platelet, peripheral smear also showing some leukocytosis, and not very significant change. She was monitored for vital, and because of the high BP, we gave her labetalol infusion and a loading dose of injection magnesium sulfate according to Zuspan regime as just described. There was actually not much relief in the imminent signs, but she was not throwing any convulsion. So since the imminent signs were still persisting, headache was still persisting, we did an emergency cesarean section. We found minimal ascites, but the surgery went off okay. And we shifted her to HDU because, the hypertension was also responding after delivery. We maintained the injection magnesium sulfate. And the next day morning, the POD 0 itself, we saw that the woman had 3 episodes of GTCS. So we have delivered her, but still she had convulsions, because often we feel that with delivery it will all go away. So it doesn't go away. In some cases, this unfortunate woman, in spite of standard management, developed convulsions. And as Dr. Mandrupkar just now told, an additional 2-gram loading dose was given during the seizure episode, because that is the best thing to do. She's already on maintenance dose, you top it up with 2-gram more. But then, it didn't help also. So injection Levipril was started. And both these were continued for 24 hours. Labetalol infusion was continued. And finally, with this, she stabilized. And then this woman, when she was finally discharged, she was still found to be hypertensive. And she was on 2 drugs for the hypertension, labetalol and Cilacar. Probably, that could have been replaced by amlodipine, but it was like that. So eclampsia, severe preeclampsia will be at risk for postpartum eclampsia as well, even with prophylactic magnesium therapy. So beware. It is important to monitor them very closely for 24 to 48 hours, because postpartum eclampsia indicates that the woman's background disease nature is very severe. Right? Because even after delivery, if the disease is still there, if the microvascular circulation or disease still going on, the process is still there, that means that the underlying nature of the disease is very severe. Women who do not respond will merit 2 or even 3 drugs at a time for control of convulsions. I have found sometimes that even sodium valproate needs to be added to these 2 drugs, and they also merit imaging of the brain, because we may miss a cerebrovascular accident or even severe cerebral edema, which also requires anti-edema measures to bring down the recurrence of convulsion. Aggressive management of hypertension is essential to avoid cerebrovascular accidents. And what Dr. Mandrupkar was saying was very true, that magnesium sulfate does not help us in control of hypertension, but it has got a benefit in stabilizing membranes, and also has a benefit in restoring the autoregulation of cerebral circulation. So that is how it prevents, further convulsions. Any which way, this woman had to be given more than magnesium sulfate. And of course, multidisciplinary approach is mandatory. So don't fail to bring in all the specialists available, especially the neurophysician at this point of time, because I think it's important. A very quick look at what is the current take on the investigation and evaluation. Of course, this will depend on what every center has in your armamentarium, but it does not, it is important to always know that we have done the best for our women. That is what is important to know. And what we cannot do, we are aware. And we are able to refer or, for further testing, etc. That is what is important. So this is something standard, which is there in all the guidelines. And of course, this is an excerpt from up to date. And I will not go through this, but it indicates that what is the meaning of severe preeclampsia, the diagnostic criteria for preeclampsia. And as my previous speakers have told, that there is in today's setting, there is nothing like mild, moderate, and severe. It is severe and non-severe. So we understand that whatever is seen here is all, it is describing when we can call it as severe. The other thing which has changed with the ISSHP classification is the presence of proteinuria is no longer mandatory to diagnose preeclampsia. It is very, very true. But the presence of proteinuria indicates severity of the disease. That has not gone away. So the moment there is protein in the urine, significant proteinuria in the urine, then we must be aware that we are seeing something progressive here. So in patients with preeclampsia, the presence of one or more following indicates preeclampsia with severe features. Again, no details will be discussed now. We know about the blood pressure levels. We know the central nervous system dysfunction. So please be sure to evaluate the central nervous system. I think nobody understands this disease better than obstetricians. So this is one medical problem which we do not refer. The basic diagnosis we do only if the organ damage is there, we call for the other specialist, but we need to pick up if the brain is affected. So we need to be able to pick up that visual problems or the headache or the description that the woman gives. The hepatic abnormality we need to pick up as pain or, thrombocytopenia as fatigue in the lab test and renal insufficiency, and the presence of pulmonary edema. So don't miss the incipient features of breathlessness, etc., when they come with, because initially it can be very, very tricky to diagnose. The prompt evaluation, where is all we should be always thinking. So when do you evaluate women for preeclampsia? All pregnant patients with new onset hypertension or worsening hypertension of a pre-existing chronic hypertension after 20 weeks with, or signs and symptoms of impending eclampsia and maternal or fetal compromise, you need to evaluate. Where, as an inpatient or an outpatient, some women require inpatient to get evaluated for initial maternal and fetal evaluation and management also, because then, you need to put the standard treatment in place. If you're contemplating discharging them and not delivering them, you must admit them, evaluate them, start the treatment and give them the plan of care, and they can again come back after discharge. So women with severe hypertension, systolic and more than diastolic 110, and or signs symptoms of impending eclampsia and maternal or fetal compromise, in these women inpatient therapy is needed if there is all these features. When can you treat them as outpatient? Non-severe hypertension, that means less than 160 systolic and less than 110. But I must tell you that I personally do not have the courage to treat a woman as an outpatient when it is more than 100. The diastolic is more than 100 or the systolic is more than 150. That is my individual level of courage. You have to decide for yourself. So non-severe hypertension, which is asymptomatic, she shouldn't be having any symptoms related to it. And she should be followed closely as outpatient, provided they're seen frequently and the mother is doing well and the baby is doing well. So that is important. Both mother and baby should be well. Lab test, you are all used to doing this, the CBC, the creatinine, the liver enzymes, and then a quantitative protein estimation, a little better, though it does not qualify for diagnosis, but if quantitatively you know how much protein is getting thrown out every day, it indicates the basic nature of the disease. Because after all, the nephrotic unit in the kidney, that the damage which happens to the glomerular capsule or the nephrons, that actually indicates how severe the disease is. Let us not forget that. That was in the very beginning, kidney biopsies used to be done, when Sibai was conducting his studies to diagnose this disease. So please be sure that how much protein is getting thrown out, because sometimes we feel that the kidneys have become like one, sieve. They're just letting out the protein without any control. So be sure that we pick that up. In women with abnormal liver chemistries, we go on to the next level. Additional lab testing is LDH, and coagulation studies are a must. They will be done if platelets are low or liver is affected. PT, APTT, fibrinogen are ideal, and automatically you get the INR. If any other complication are there, it's all the more important. And if there are any signs of upper abdominal pain, etc., or already severe liver dysfunction, do think about doing a glucose level. Even though previous, GTT is done, etc., etc., at that point, do a glucose, because hypoglycemia will allow you to pick up AFLP, right? You know that. Then amylase, lipase, and ammonia levels also will give us some differential diagnosis. Now we have spoken about angiogenic, proangiogenic factors. So shall I wind up? This is already covered. And assessment of fetal status, I think everyone is familiar with the ultrasound monitoring of the fetus. When to obtain cross consultation, I have already spoken. This is one thing, this is the last slide I have, that we did have a recent case of microangiopathic hemolytic anemia, and she's still in the ICU, she's not discharged. So sometimes in eclampsia or in HELP syndrome, you come across these rare situations, thrombocytopenia, hemolysis, fragmented red cells, but the neurological findings are very, very severe. There is a lot of headache, there is a lot of cerebral edema, and a normal clotting screen will be normal. In TTP, they do not have the picture of DIC, and they have this EDAM MTS 13 activity, which is diagnostic actually, but it is, I do not know how much it is available anywhere. We did have this and it came out as negative for her, so we continue to treat her as DIC. Now this condition is important to pick up because the management will differ. They will not respond to platelet transfusion. We'll have to give them plasmapheresis. So this is how I end. And I hope I have answered some of your questions. Remaining is open for discussion. Thank you very much.
Thank you, Jyoti. Thank you, Shobha. So I think we've had a good cases there, it actually sort of lends a reality to that particular talk. Dr. Gora, can I have you come on the stage, please? Dr. Myers is already there, and we'll just run through a few questions before we break for dinner. Can we have the lights on here, because I need to see the questions? Can we have the lights on, please? I think we'll start with Professor Jenny Myers. Thanks for logging back, Dr. Myers. The question for you is there any role of diuretics at all in the management of severe preeclampsia? Professor Myers?
Hi there, can you hear me okay?
Can you unmute her, please? Or mute yourself?
Yeah, I'm unmuted. Can you hear me? Can you hear me?
Yes, please.
Yes, you can. Okay, great. Well, hi again. The question about diuretics. I think the short answer is no, they don't have a role in the treatment of severe preeclampsia with severe features. There are situations where we've all seen women have very significant acute kidney injuries and ATN and become severely oliguric in the context of severe preeclampsia. And in that situation, sometimes a bit of a kickstart to the kidneys with some diuretics does help to offload that fluid overload that accompanies that severe oliguria. But we would certainly, I wouldn't instigate diuretic therapy until we were certainly through that first 24, 48, 72 hours, when usually that severe kidney injury is starting to resolve. There have been a few cases where we have resorted to using diuretics when we're 3 or 4 days out. And to be honest, when there's a very severe kidney injury, diuretics often don't work. But other than that, we wouldn't use them. And certainly pre-delivery, I don't think there's a place for diuretic therapy. It will just make the women with severe preeclampsia have got a very intravascularly depleted. That intravascular volume is very concentrated, and that obviously they've got a lot of extracellular fluid, but diuretics don't help that.
Right, thank you. And there's another question. If the BP is not controlled with the maximal dose of labetalol as well as nifedipine, is there anything else that you can use to control the BP, or would you say we just terminate the pregnancy? This is a question coming from Dr. Ghosh.
Okay, yeah, no, so I guess it depends on the clinical presentation, but if I were to take a woman during pregnancy, the antenatal management of hypertension, and a woman who we're not considering delivery and we don't think has got preeclampsia, it's not that uncommon for me to have women on 3 or 4 antihypertensive agents to treat and maintain their blood pressure in a safe zone. We have some women with very, very resistant hypertension who need 3 or 4 antihypertensives throughout pregnancy. In a setting of preeclampsia, where we're kind of trying to keep a woman stable, perhaps we're balancing that risk of prematurity versus severity of disease, then I would again escalate with labetalol, nifedipine, doxazosine, methyl hydralazine, and I would maintain blood pressure safely. I very rarely make decisions to deliver a baby based on blood pressure alone. I take blood pressure very seriously, as I've already said, but I would very rarely make a decision to deliver preterm. At term, it's different, but preterm, I wouldn't make a decision to deliver usually based just on blood pressure. When the biochemistry and hematology is becoming abnormal, you've got evidence of end organ disease, and you've got evidence of fetal compromise, they would be the things that would trigger delivery. But usually we can, by stacking up the antihypertensives, we can usually get blood pressure safe.
Right. Thank you. Thank you very much. Dr. Gorak, there's a question for you. Would you treat delta hypertension with injection magnesium sulfate? There's a new term, so just quickly tell us what delta hypertension. The word is actually delta eclampsia. Yeah.
The word actually is delta eclampsia. It is not a delta hypertension. Where what happens ki the blood pressure is normal. Maybe normal means it might be lower side. On lower side, maybe 140/90, but the patient gets eclampsia. So in such situation, it is called as, it is a sudden rise in the mean arterial pressure, which is over the only in last trimester somewhere, and it causes eclampsia. And usually these cases, they present with PRES, that is encephalopathy. And in such cases, definitely, yes, magnesium sulfate has a role for the prevention of the further eclamptic convulsion. Per se, if it is asked as only hypertension, then no. It's a very clear-cut guideline that, again, I will repeat, 160, 110, we should use it. Any blood pressure with any premonitory symptom, any blood pressure with abnormal blood investigation, we must use magnesium sulfate to prevent eclampsia.
The second question is, if you've given magnesium sulfate for a severe preeclampsia and the patient's BP settles down, will you continue the pregnancy if she's less than 34 weeks, or will you prefer to deliver her?
Definitely, here, she is the case of severe preeclampsia. We have given her magnesium sulfate to prevent the eclampsia. So now, if she is settled with good antihypertensives, there is no eclampsia, definitely we can prolong the pregnancy sufficiently enough, monitoring the fetal as well as the maternal bad signs. But yes, definitely we can do the expectant management at least for 24 to 48 hours till the fetal lung maturity is achieved with the steroids.
Right. And what is always recommended, if you're considering to do a conservative management, as he very rightly said, you must do it in a tertiary care center where you've got all the facilities for monitoring. You cannot just prolong the pregnancy indefinitely. You decide 3 days, 4 days, 24 hours, 48 hours, but that's the time limit that you're waiting because you don't want to get into a second severe phase.
Shall I add something?
Yes, please.
Here, I would like to add something regarding the steroids, because what happens in such cases, if we use the high doses of the steroids, definitely again it is going to shoot up the BP. And if patient is associated diabetic, then again it is going to shoot up the sugar. So in such cases, we have to use enough dosages, but Government of India or the Indian Association of Pediatric or NNF says it is 6, 6, 6, 6 within 24 hours. So if we use such dosages, then definitely the 24 hours have gone. the total dose of 24 gram in 24 milligram in 24 hours is been used, and definitely there is no sudden rise in the blood pressure. So that we have to keep in mind.
Right. And, there was a question of steroids in, for lung maturity beyond 34 weeks. Professor Myers, in India, we are still using steroids right up to 37 weeks, though the guidelines mention 34, because it depends on which place the patient is. Sometimes she's not in a tertiary care center with a beta in ICU, but I know all the guidelines say that beyond 34 weeks, you don't really need to give steroids and you can still deliver the patient. So I think, that is something which we agree upon. And just a second, there's another question for Shobha. Is there an earlier way to diagnose HELP? Instead of waiting for the full-blown HELP to rise, can we pick it up much more earlier?
Yeah, I think when a woman complains of extreme fatigue, as I said already, we must do a complete blood count and a peripheral smear. And I think there is a way of picking up microangiopathic hemolysis earlier. There is the other test which I mentioned, DAM-TS13. I don't think it is so. That also indicates hemolysis, microangiopathic hemolysis. So, but they are not easily available. Clinical diagnosis of, is the clinical pointers of severe fatigue and listlessness and sometimes lack of sleep. And then we test them, see them at more frequent intervals, and progression of the hypertension also will give an indication.
Right. One of the
maybe LDH
right.
evaluation.
LDH, in fact, what is recommended that an early rise of LDH could also mean it could be a partial help. Immediately catch the patient there, and this is also recommended.
LDH. The only thing is we have to keep in mind the normal pregnancy level. Even in normal pregnancy, the LDH raises. So if it goes up to 600, it is fine.
Beyond 600.
If it is going beyond 600, definitely it is that
questions from the audience, if any? Yes, please.
We've got two questions. One is for ma'am. What is the role of low molecular weight heparin, especially in these severe PIH patients whom we have delivered?
There is no role of low molecular weight heparin except in situations where you have a positive APLA syndrome or a previous history of DVT, or say you've got a patient who's got a severe preeclampsia undergoing a C-section, and she's got all the high risk factors, obesity, hypertension, she's been resting for a longer period of time, then those are the standard indications. But particularly for preeclampsia, there is no role. Low molecular weight heparin does not prevent preeclampsia, neither does it prevent eclampsia. So there is no role of low dose heparin at all, unless you're giving it for the indications like a BOH, recurrent pregnancy loss, and there is a positive indication, inherited or acquired thrombophilia positive. That's the only role.
And one question for Dr. Gorak. We are dealing with a lot of patients now who are coming with morbid obesities of weights of 120, 125. So is there any change in the dosage of the Pritchard's regimen, or do we stick to the 14 grams and 5 grams orally?
We stick to the same because it is not the dose which is not decided on the per kg body weight, but it is on the serum magnesium level which is achieved with that dosages. So it is the same dose.
Just as you don't reduce the dose, you're not also increasing the dose. And yes, please.
Luckily, maybe I would say in the metro city, we are having less eclampsias, but unfortunately, we are having more of this test tube baby intracranial hemorrhage, venous thrombosis and everything. So we must examine patient clearly, pupils and lateralizing signs and everything. Today morning, everybody, all of us woke up to the news. Our Padma Shri, Bmj Shri, she was admitted and treated for aneurysm. So there are many undiagnosed things which are there, especially in Dr. Shobha Madam's case, that 18-year-old girl, when the sorry, ma'am, your name. So when the convulsion recurs, it is good to rule out intracranial lesions because there are background potentially difficult cases that a 18-year-old girl was lucky, but otherwise with the use of contraceptive and elderly ladies, we are seeing other scenarios which are very difficult to handle. And eclampsias, luckily all of us are really pro, and it was a great revision today going back to school, that way. But we are not getting cases. We are getting cases of TTPs and hemolytic uremic syndrome and hemorrhages. Everything. Thank you.
Can I just say one thing? Back to the older days, we were told, I was working at Sion Hospital and Michelle and Malcolm both are here. They would bear with me that if a patient is given magnesium sulfate, she's come with convulsions, you've given a magnesium sulfate, and the convulsions still go beyond and she's not responding, that there is some intracerebral problem. So either she could be having a cysticercosis or she could be having tuberculosis or tuberculoma, or there could be something more, a neurological manifestation. So at that time, ask for a medical opinion, and in this case a CT MRI is indicated.
Have low threshold for CT scan or MRI in such case.
Even in that case, one must not, one must keep in mind that is cerebral malaria, because again that this diagnosis is very common. If the patient is coming from the maybe from the Ishanya Bharat, that part of northern eastern part, then probably again Kala Azar and all we have to keep in mind, because these diagnoses are very common about them.
But if you give the first dose of Maxilf, and later on, if they want to, the physicians want to shift over to diphenyl hydantoin, not for because it's eclampsia, but because there is some other problem or there is a malaria, they want to start. There is no harm done if you've given the first dose of Maxilf. And there was the last question, which I'm just going to answer. They said the second trimester predictors, are they available? And could you just elaborate on that? So let me tell you that the second trimester predictors are available. The S-FLIT ratio, that is S-FLIT upon PLGF. So S-FLIT is anti-angiogenic and PLGF is pro-angiogenic. So if the ratio is rising, it's a predictor of pre-eclampsia. So if the ratio is more than 85, it means that the patient will have an early onset PE in the next 8 to 10 days. It's only valid for 8 to 10 days, which means it has to be repeated. But you've got those precious 8 days. If it is between 38 to 85, you're fairly certain that within the next 8 days, you will not get preeclampsia. But if it is 100 and above, it means that this patient surely will get a late onset preeclampsia. So you have to act. If you want to transfer her, you can. This test costs in India, currently in Mumbai, 6,000 rupees, 5,800. But if you're clubbing it with some other test, the cost becomes slightly higher. It is available in the metro cities, but I don't know of the availability in smaller places.
Right. Here I would like to add the 0 rupees test. And again, it is just a score. Because again, if we see in a second trimester, definitely it is going to work very well. The maternal factors along with MAP, because already we are in second trimester. So the maternal weight gain, even the anemia, even the TSH and the GCT has been repeated twice. So already we can understand whether in second trimester my patient is at risk. So by this, so 0 rupees test, we can definitely do justosis score again and again. Here one thing just I would like to add, Madam has already discussed about that. The justosis score is a dynamic score. When all other tests, they are being advised only at once. But justosis score, definitely we can do at first visit and again every visit till 28 weeks. And definitely if the score was 2 initially, then in later visit, some factor may come up and we can add the risk again. And from that point, patient can become at risk to develop the preeclampsia, and we can start the preventive strategy right from there. Though it may not reduce the incidence of preeclampsia, definitely Professor will agree that the late aspirin, though it will not prevent the preeclampsia, definitely it is going to reduce the complications of preeclampsia. Professor Myers, what is your opinion on that?
We wouldn't usually start aspirin later on in the pregnancy after about 16 weeks, because although it's unlikely to do any harm, its evidence would suggest it probably won't make a big difference to that early placentation, which drives the development of severe early onset preeclampsia. So we wouldn't usually start it after about 16 weeks, certainly not after 20 weeks. That, as I say, not because I think it will cause any harm, but I think the evidence suggests it probably won't reduce the placental component of the disease.
Right. I think, I think there's a lot of evidence in what she said, that after 16 to 18 weeks, I mean that after 20 weeks, many people start low dose aspirin. At 30 weeks, it doesn't really help. But yes, if you have the split and PLGF score, it just tells you how serious this patient is. And I think that's the basis of, some of the trials which are going on. The Parrot one is already, we already know about that. But the Parrot 2 trials, I think the results are awaited. Right, Professor Jenny?
Yeah, so the Parrot 2 results are actually were just presented to the co-investigators this week.
Right.
So the data is done and we discussed it this week. Lots of very interesting and in some places quite confusing results. So we wait, we will be presenting those soon. I think we need to be careful about repeating a test that is expensive, and we need to make sure that the indication for repeating the test is there. So I think we don't need to use the test in women who've got a clear diagnosis. That's the first thing. We need to save the test for those women where it's not clear and you're not sure how much surveillance the woman needs and whether she needs to be near a secondary care or tertiary setting, for example. So I think we need to be using it carefully to make those kind of decisions rather than using it as a kind of, it's too expensive a test for any of us to be able to use it as a screening test for all and repeating it in all pregnancies.
Okay, all right.
Professor, can I ask you one question that even NICE guidelines have mentioned that aspirin 75 to 150 milligram, right?
Yeah.
So for whom you are using 75, for whom you are using 150, what is being followed there?
Yeah, so in the UK, it's still a little bit variable, but after the Asprey trial, most units are now using 150 milligrams for everyone. There are a few places that still use 75 because of nervousness around the increased risk of postpartum hemorrhage, for example. But the Asprey trial showed the efficacy of 150, and it showed, there were no serious adverse consequences of using 150. So I have to say I use 150 milligrams routinely. There is, some people would still love to do the trial where we compare 75 with 150. I'm not sure it's worth it. Personally, I think we should probably spend our money on other things and offer women 150.
So are there any trials or what is your experience regarding the comparison of 75 with 150?
So nobody's done, as far as I'm aware, nobody's done that direct comparison. They've tried to do it a little bit from the from IPD and meta-analysis of the previously reported trials, but no one's done a prospective trial, as far as I know, comparing 75 to 150 in high-risk women. So I don't know. I personally, I think we've got really good data from Asprey that 150 milligrams works. And so lots of us certainly don't see a reason not to give 150 milligrams. I think not many women remember to take it every day. And 150 on alternate days is probably better than 75 on alternate days. So on that basis alone, I prescribe 150.
Right. Thank you very much. I think, it has been an interesting session for all of us. We've learned a lot. And, with the experiences, from India and from UK, and, now we fortunately have access to, all the studies, so which we keep, going through our, our internets. And I think all of us are wiser now because we have magnesium sulfate, we have low dose aspirin, we have better methods of diagnosis. So I'm sure all of you would agree that it was a good session. I'm not talking about myself. I'm talking about Dr. Mandrupkar, Dr. Shobha Gudi, Professor Jenny Myers. And I must thank the BMJ for getting all of us together and making us, sort of think a little more out of the box to see what else is there. And I'd also like to thank Pfizer for having supported this particular academic movement. And once again, thanks to all of you for staying back for the BMJ Masterclass. And thanks again to all the viewers over the 16 satellite centers. There were more than 150 people. Some of them logged in at 7 because we told them this time was 7. But we are sorry about the delay. But I think overall it was an interesting session. So Professor Myers, thank you very much. And we'll have you come over sometime to India physically. So then,
Yes.
we will bombard you with more questions.
Please do.
Oh, I'd love to.
Please do visit.
Oh, thank you. I'd love to. That'd be great.
Right. So thanks
Thank you.
to all my colleagues who've been here. Gorak has come all the way from Islampur, and Shobha Gudis come all the way from Bangalore. I've come from Santa Cruz West. I'm just right here. So thank you and good night,
BMJ,
and
thank you,
enjoy
Pfizer,
the
and
dinner.
thank you all of you.
Thank you so much for your patient hearing. We'll just hold you for 1 minute, if you can bear with us. I know we started very late. We like to call our sponsor, Priyanka Manani. She's the country brand lead, and we'd like to officially close by felicitating our faculty.
Dear doctors, on behalf of Pfizer, I would like to thank all the HCPs joining us at the hub location at Mumbai, 16 spoke locations across the country, and the doctors who have joined us on the virtual mode. Thank you for joining us today for this masterclass, which is a platform that brings international and national perspectives on a very important topic, hypertensive disorders in pregnancy, which is one of the major cause of maternal morbidity and mortality. This is more painful to hear, knowing that this can be managed with early diagnosis and accurate management. Being the innovator of folic acid, the molecule that helps prevention of spina bifida in millions of babies today, to pioneering the segment of hormonal support in contraception and menopause management, at Pfizer Women's Healthcare, we are committed in our endeavor to improve health outcomes in millions of females across life stages. However, this strive can never be possible without the support of HCPs who've kept their trust strong in Pfizer. Hence, I would once again like to thank all of you for joining us today. I would like to extend gratification to our esteemed international speaker, Professor Jenny Mayers, our national faculty expert, Dr. Suchitra Pandit, Dr. Shobha Gudi, and Dr. Gorak Mandrupkar for the deep insights and practice principles for management and diagnosis of hypertensive disorders in pregnancy. I would also like to thank the moderators at 16 spoke locations, Dr. Mangla Dogra at Chandigarh, Dr. Sonia Nayak, New Delhi, Dr. Shailesh Jain, Jaipur, Dr. Renu Laktakya at Lucknow, Dr. Aarti Luthra, Dehradun, Dr. Shanti Roy, Patna, Dr. Kushagridi Ghosh at Kolkata, Dr. M. Tripura Sundari at Hyderabad, Dr. N. Hebzibat Kirubamani at Chennai, Dr. George Joy Eradil at Kochi, Dr. Sumati N. at Madurai, Dr. Shilpa Naik at Pune, Dr. Shobna Sultan Bhopal, Dr. Asha Jain at Raipur location, Dr. Shilpa Shukla at Baroda, and Dr. Indu Singh at Varanasi. A big thank you to all of you for sharing your practice guidance with the doctors at spoke locations. Last but not the least, thank you to BMJ for providing this platform to us. We look forward to move together in our endeavor to support her health throughout her life stages. I would now like to invite Mr. Suminder Behel, the commercial lead at Women's Healthcare Pfizer, for handing over the token of gratitude to our speakers.
Yeah, she won't be seen. Professor Myers, yeah, give it to her. That's what I said. Yeah, so just give it to her. Just show it. No. Show it like that.
Professor Myers, we couldn't have you here physically, but we would love to have you with us soon for the next programs.
Great. Thank you so much. Thank you for having me.
Thank you so much.